So hi guys. Um, this is INI-CET grant test number 2. Okay. I hope you all have completed writing the grant test number 1 and you are also writing the daily challenge. Okay, because daily challenge is purely INI-CET based and we have curated PYTs from the previous questions of INI-CET and we have modified the questions and given you 20 questions per day. I think it has been running for the past 20 to 25 days, and we have almost covered around 400 to 500 of the most important questions for INCT. So, anybody who wish to know more about what our app is providing, please contact our the concerned faculties or the concerned staff. Please make use of all these facilities that is available in the app. You have a lot of options available. Even the revision videos are so beautifully curated that it will give you an extra edge for the INCT. So without further ado, we will start with the questions. So this is a grand test discussion. It won't be that elaborate. We'll be just rushing through the topics. If you want detailed information, you can always go to the app and look back at the videos and you can just read the notes. Okay. So any disparity that is being discussed here, always go by your notes. Okay. Any disparity, if you get any disparities, always go by what is there given in your notes. You never need to change whatever you have studied. Okay. So you have a 12-year-old boy for a routine eye examination. Best corrected visual acuity 6 by 9 in both eyes. His father had a significant vision loss in his 40s. Now, fundus reveals the findings shown in the image. So, they are asking which is the most specific image for confirming the diagnosis. So, there is a family history of, okay, there is a family history of early vision loss. Okay, and in the fundus, you see around the fundus you see a yolk like lesion. Okay, egg yolk like lesion, and it is called as vitelliform macular dystrophy. Okay, vitelliform macular dystrophy, and the diagnosis is best disease, best vitelliform macular dystrophy. Okay, best vitelliform macular dystrophy. Okay, now the best investigation would be EOG, electrooculogram. Why? Because EOG assesses the RPE function or the function of the retinal pigment epithelium. Okay, EOG assesses the RPE function or the functions of the retinal pigment epithelium, and there is reduced Arden ratio in Best disease, and that is actually diagnostic. Okay, now ERG, where do you use ERG? ERG is used for photoreceptor function, whereas visual evoked potential VEP is for optic pathway lesions. Okay, and OCT is for structural diseases of the retina. Okay, now moving on to the second question. Assertion is administration of TT vaccine provides long-lasting active immunity against tetanus. That is true. Second, the reason is primary protective mechanism involves the production of secretory IgA antibodies that neutralize the tetanus neurotoxin mucosa. No, that is wrong. Why? Because tetanus toxoid, okay, it gives you humoral IgG mediated toxin neutralization. Okay. So whenever you read an assertion reason question, after seeing the assertion, don't go by the predisposition that okay, reason would be correct and it would be A. No, it won't be. Okay. So always go to the next option and then see, then decide between A and B. Okay. What is secretory IgA? It gives mucosal immunity. Okay. So A is true and B is false. I mean, reason is false. Now, question number three. A 14-year-old girl is evaluated for primary amenorrhea and there is this finding. What is the finding? The finding shows there is a imperforate hymen. Okay, there is imperforate hymen. Okay, and what is the management of imperforate hymen? It is cruciate hymenectomy. I mean hymenotomy. Okay, okay. Now, where do you do vaginoplasty? You do it for MRKH, Mayor Occupancy Kushner Foster syndrome. Where do you give COC pills? Nothing, not here. It is given in infertility. Okay, or into induced ovulation. Where do you give laparoscopic drainage of the hematometra? Okay, it is being dealt when there is outflow obstruction. Okay, that's it. Now, question number four. 80-year-old well-controlled hypertensive male visits for a routine health check, which is not regularly recommended. So, in a elderly, HPV is not recommended. What is the ideal age for HPV vaccine? You give it in 9 to 26 years. Okay, but actually now it has been extended, but still not never gives at 80 years and all. Okay, so zoster is a key. Zoster is very important. Okay, zoster is important in the elderly patients. Now, question number five. Match the disease in column A with their corresponding causative organism in column B. So, Oriya fever is caused by Bartonella bacilliformis. Okay, rat bite fever is caused by Spirillum minus. Okay, it is also called as Sodoku. Okay, Sodoku. But made fever also. Now, Donovanosis is caused by Klebsiella granulomatosis. And Pinta is caused by Treponema cariata. By Yos and Pinta has been eradicated. Okay, so the answer is P3Q4 R1S2. Okay, now question number six. For the optimal triangulation and ergonomic dissection as depicted in the diagram, which is ideal azimuth angle between the camera port and working instrument. So they are telling, so between the camera and the instruments, the ideal angle should be 60-degree. Okay, so that it involves this, like it reduces the sword fighting. Two people standing like this. Okay, that will be prevented. Okay, okay. Now, question number seven. So they are telling about ibalizumab. So ibalizumab is a monoclonal antibody against the CD4 receptor domain. CD4 receptor domain. Okay, it prevents the conformational change and blocks the viral entry post attachment. Okay, prevents conformational change and blocks viral entry post attachment. Okay, so here assertion and reason are true and it is a correct explanation. Okay, now question number eight. Now they are talking about rucaparib. So rucaparib is actually a PARP inhibitor, PARP inhibitor. Okay. Now, what happens in BRCA mutation when there is BRCA mutation? Okay, there is defective homologous recombination, and in PARP mutation, Okay. In PARP mutation or PARP inhibition, in PARP inhibition, DNA damage. There is DNA damage and it accumulates, leading to tumor cell death. Okay. Now, why is it not DHFR inhibition? It is by methotrexate. Okay. VEGF inhibitor, it is example is bevacizumab. And PDL1 inhibitor is used in immunotherapy. Okay, excuse me. I'm taking this revision from my OPD. So that is why you hear a lot of noises. Okay. I'm extremely sorry. Okay. So it is the induction of synthetic lethality. Okay. Now question number 9. Now, which of the following would be considered as a primary treatment failure? Okay. Feature of primary treatment failure. Okay. In SAM or kwashiorkor. Okay. So why did you say this is kwashiorkor? Because it is SAM with edema. Okay. So SAM with edema, it is kwashiorkor, and the patient is on F75 therapeutic feed. So in SAM management, okay, in SAM management, the earliest and most reliable sign of recovery, earliest and most reliable sign of recovery, okay, the earliest and the most reliable sign of recovery is the return of appetite. Okay, child will answer that he or she wants to have food. Okay, so return of appetite is the earliest and the most reliable sign of recovery in a SAM child. Okay, what does it indicate? Indicates there is metabolic stabilization, there is a resolution of infection or toxicity, and also there is shift from the stabilization phase to the rehab phase. You can give a funder or RETF. Okay. Now, so if the appetite does not return by day 4 to day 5 or day 3 to day 5, then it is defined as primary treatment failure. So, what are the other features of primary treatment failure? When do you say there is a primary treatment failure? So, you call it a primary treatment failure, okay, when there is no return of appetite or when there is persistent edema or when there is clinical deterioration or when there is a failure to improve the metabolic status. Okay, that's it. Okay, now we move on to question number 10. So now there is a history of syncope in a young athlete. Okay, there is a history of syncope in a young athlete Okay, with family history. Okay, now what is the diagnosis here? Okay, he reports intermittent palpitations for the past few months, and family history is also there. Okay, so there is no. Okay, so okay, so if it was a HOCM, if it was an HOCM, what would have been the ECG findings? The ECG findings would have been LVH with deep Q waves. And what do you see? You see this one, ASH, ASH plus SAM. What is ASH plus SAM? Asymmetrical septal hypertrophy with systolic anterior motion of the mitral valve leaflets. Okay, that would have been seen if it was a hypertrophic obstructive cardiomyopathy. And also in the ECG, there would have been features of LVH. But here you have, okay, V1 to V3 T wave inversions and epsilon waves. Okay, so hence the diagnosis is arrhythmogenic RV, arrhythmogenic RV cardiomyopathy. Or ARVC. Okay, where there is fibro-fatty infiltration and replacement of the RV free wall. Whereas if it was Hawcom, it would have been the LV that is involved. Okay, it would have been the LV that is involved and the septum. Okay, now question number 11. Okay, so what does question number 11 say? Question number 11 says there is a 58-year-old old male who is a retired factory worker who comes with a chronic ear discharge. He comes with a chronic ear discharge with hearing loss. Okay, and there is a 15-year history of foul smelling discharge. Okay, there is a 15-year this history of foul smelling discharge with progressive hearing loss and granulation tissue. Okay, so this is actually a COM Attico andral type. It is a COM Attico andral type. So COM has two types. One is the tuber-tympanic type, and the second one is the unsafe type. Tuber-tympanic type is the safe type, which has a central perforation with mucosal disease without any bone destruction and less offensive discharge. Whereas if it is an unsafe ear or an atticoantral type, there will be a marginal rhatic perforation with associated cholesteatoma. There will be bone erosion with the granulation tissue and foul smelling discharge. Okay, that's it. Now, question number 12. Okay, so they are asking for the bridge population. Okay, Bridge population in HIV transmission are the long distance truck workers. Okay. Now, who are the other bridge populations? They can be the migrant workers and the clients of sex workers. Now, who are the mm, core high risk population? Core high risk population. The core high risk population are the female sex workers, men having sex with men, and the intravenous drug abuse. Okay, all these are. Now, bridge population. So, bridge population interact with the high risk group and transmit the infection to general population. Okay, that's it. Now, question number 13. 28-year-old construction worker. Okay, now there is a chemical eye injury. Okay, so chemical eye injury and irrigation is being done. Okay, when to stop the irrigation? So cement splash means that there is an alkali burn, okay, which is more severe than acid. So the patient presents with limbal ischemia and blanching. So you start immediate irrigation. Okay. So when do you do irrigation? When do you stop irrigation? So you do copious irrigation. Okay. And stop at physiological pH in the conjunctival sac. Physiological pH in conjunctival sac. What is the physiological pH of the conjunctival sac? It's 7.0 to 7.4. You check using a litmus paper. Okay, and it should be stable after 5 to 10 minutes. Okay, that's it. Okay, now question number 14. Okay, so 45-year-old male. Now there is a patient with a massive transfusion, but there is persistent tissue hypoxia. Okay, sorry. So massive transfusion with persistent tissue hypoxia. Okay, so massive transfusion with persistent tissue hypoxia. What do you do? There is a hemorrhagic shock. There are 8 units of PRBC being transfused. Blood is being stored for 28 days. Okay, so there is a confusion and the metabolic acidosis history. Okay, that actually means there is persistent tissue hypoxia. Okay, so what is the core concept? When so prolonged storage of PRBCs with prolonged storage of PRBCs, what will happens? There will be reduced 2,3-BPG, there will be reduced ATP, there will be reduced RBC deformability, and there will be increased amount of potassium. Okay, so there is reduced 2,3-BPG, and thus it reduces the affinity of hemoglobin for oxygen. Okay, reduces HP affinity for oxygen. Okay, so also ODC shifts to the left. Okay, there is no oxygen release, and hence there is functional hypoxia despite a normal HP. Okay, that's it. Okay, so it is not. So which of the following physiological changes experience? So the discrepancy is not decrease, not potassium. Okay, I'm sorry. It is the decreased levels of 2,3-BPG. Okay, okay, it is reduced 2,3-BPG. Okay. Now, question number 15. A primary gravida at 39 weeks of gestation has an uncomplicated vaginal delivery. So, which step is not recommended in AMTSL? So, it is actually they are telling early cord clamping. So, early cord clamping is not recommended. Okay, always you go for delayed cord clamping because it gives increased neonatal iron stores, reduced anemia, and better neonatal outputs. Okay, now moving on to question number 16. Okay, so what does 16 say? So 16 gives us a idli shaped hematoma. So idli shaped hematoma is actually EDH. So which is the artery responsible? So the artery responsible for the idli shaped EDH is actually the MMA or the middle meningeal artery. Okay, middle meningeal artery, and middle meningeal artery enters via the foramen spinosum. Okay, okay. Now foramen rotundum transfers the rotundum, the maxillary nerve. Okay, it transmits the maxillary nerve. Foramen ovale, mandibular nerve. And jugular foramen, cranial nerve 9, 10, 11, plus the IJ. Okay, that's it. Now, question number 17. Okay, a 55-year-old gardener, okay, with a non healing ulcer. So, rose gardener's disease will be sporotrichosis. Okay, so sporotrichosis. They are actually dimorphic fungi. What are the other dimorphic fungi? Histoplasma, plasma capsulatum. Though the name has capsulatum, it is not capsulated. Okay, blastomyces, coccidioids, paracoccidioids, then penicillium or Tulanomyces marnathi, and Sporothrix schenki. So these are the dimorphic fungi. So when you have a rose gardener's disease or a Himalayan disease, okay, and you see a cigar shaped budding yeast. Okay, you get cigar shaped budding yeast cells. Okay, where do you get broad based budding? You get broad based budding in blastomyces. Where do you get small oval yeast within the macrophages? Okay, that is histoplasma. And where do you get spherules? You get it in coccidioids. Okay, is that clear? So there will be a lymphatic thread like this. A line will be there. Ulcer will be spreading along the lymphatics. Okay. Now, question number 18. So 18 says, 62-year-old postmenopausal woman, 3-month history of progressive abdominal distension. And what do you see? You hear, what do you get here? You get laminated calcifications. Okay, numerous laminated calcospheroids, which are called as Samoma bodies. Okay, so bilateral ovarian mass with concentric laminated calcification is seen in, one is serous cystadenoma of the ovary, then papillary carcinoma of the thyroid, or PAPCS. Okay, papillary carcinoma of the thyroid. Then you get it for meningioma, and also you get it for glucagonoma. Okay, all these conditions you get. Okay, Samoma bodies. Now, question number 19. So, 19 is actually, they are telling a 4-day history. Now, urethral smear with no urethritis with no organism on gram stain. That is the key here. So, you have a urethritis patient with no organism on gram stain. Okay, what is the, so it is actually non-gonococcal urethritis, and most commonly the organism is chlamydia trachomatis. So chlamydia is an obligate intracellular organism and it lacks the peptidoglycan, so it is not visible on gram stain. Okay, so you get a lot of PMNs. Okay, you get a, sorry. So you get a lot of polymorphonuclear leukocytes. Because why? Because there are a lot of inflammation happening. Okay. Now question number 20. Now they are telling, okay, very, very, very frequently asked question. So they are telling the physiological changes, okay, occurring in a muscle, okay, during skeletal muscle contraction. So the structure labeled X. What is the structure labeled X? It is the, what is the X? Okay, it is the head zone. It is the head zone, or okay, it is the head zone. Okay, what is head zone? Head zone is the okay, head zone. So you have the A band, you have the, I actually remembered it as high says by. Okay, that is how I said. I remembered it. What is high says by? Head zone narrows or disappears, and I band also shortens. So high says by. Okay. So head zone and the I band. Okay. Excuse me. Post OPD sleep. Okay. So H band and the I band. Okay. It shortens. So it narrows as the thin filaments are pulled towards the emblem. Okay. Now, question number 21. Now, 48-year-old male with uncontrolled diabetes presents with acute onset limb pain and systemic toxicity. They are asking rapidly progressive soft tissue infection. So, there is a severe limb pain with systemic toxicity. Okay. And so, the answer would be Streptococcus pyogenes. Why? It is necrotizing fasciitis. Okay. Necrotizing fasciitis, where you will have pain out of proportion to the infection. Okay, so okay, so it is necrotizing fasciitis. Okay, now question number 22. So what does 22 say? So which of the following factors? So whenever you have a GT, whenever you do a GT, when you have a long stem question, first read the last line, okay, and identify what they are trying to like trying to ask, what they want from the question. Okay, first look at the last line and then look at the clues. Okay, I would say look at the last line then look at the options, get an idea of what they are asking, and then read the questions. Okay, so you are asking which major factor is not a variable in the Frax tool algorithm. Okay, so you need to know what is the Frax tool. Okay, so Frax tool algorithm. Okay, it estimates the 10-year fracture risk. Okay, using what are the variables used? They use age, sex, then they use BMI, then they look for any history of prior fracture, then they look for any parental hip fracture. Okay, then they look for any history of smoking, they look for history of alcohol, history of steroid use, history of RA, rheumatoid arthritis, and history of secondary osteoporosis. So frequent falls or history of more than 2 falls per year is not included. Okay. Actually, falls are a very strong real world risk factor for fractures, but not in the crack score. Okay. Now, question number 23. So, the early onset preeclampsia, the pathogenesis is actually the second wave of trophoblastic invasion, where the spiral arteries they have a what to say the what the primarily in normal pregnancies the spiral arteries have a wide and low resistance. They are wide, spiral arteries are wide low resistance vessels. Normal pregnancy. In normal pregnancy, okay, spiral arteries are wide low resistance vessels. As they innervate the placenta, okay, there will be like so in early onset preeclampsia, what happens? The second way of trophoblastic invasion does not happen properly, and it is incomplete, and hence the artery remains narrow, high resistance. Okay, so in preeclampsia, the arteries will be incomplete. Second wave of trophoblastic invasion. Okay, there will be incomplete second wave of trophoblastic invasion, leading to placental ischemia, angiogenic factors release, and endothelial dysfunction. Okay, so this is here both A and R are true, and they are a correct explanation. Okay, now question number 24. Okay, so type 2 diabetes patient uses an ophthalmoscope. Okay, so they are telling what is the what is the image obtained in the ophthalmoscope. As you see, okay, using an ophthalmoscope, direct ophthalmoscope, you will get a virtual, erect, highly magnified image. Okay, okay, it is real inverted in indirect ophthalmoscopy. Okay, ora serrata view and all are the indirect. Okay, in slit lamp plus 90° lens, okay, it will give a real inverted image. Okay, now question number 25. Okay, so 25. Okay, is it is also another mycology question. So what are they asking? They are asking farmer who walks barefoot. Okay, so they are asking something of this foot. The classical diagnosis will be mycetoma. So mycetoma can be two types. One, it can be actinomycetoma, which is bacterial, caused by the nocardia and the actinomadura, or it can be eumycetoma or true mycetoma, which are fungal. Okay, so what can you get? You can get fine branching gram positive filaments. Okay, okay. What is a triad? Classical triad is there is swelling with sinuses plus granules. Okay, so there will be fine branching gram positive filaments. Okay, less than 1 micron diameter. Okay, now question number 26. Okay, so they are asking the primary mechanism of action. Okay, varenicline, the action is on the alpha 4 beta 2. Okay, alpha 4 beta 2. Okay, and A2. Okay, then B. B is formopizole. Formopizole is for inhibiting alcohol dehydrogenase. Okay, that's it. Okay, now question number 27. Okay, what does 27 say? 45-year-old male with a 10-year history of. Okay, okay, so this is actually the classical history of psoriatic arthritis. Okay, so what are the common features of psoriatic arthritis? Okay, so the common features of psoriatic arthritis are actually asymmetrical oligoarthritis, with DIP joint involvement, dactylitis, enthesitis, and sacroiliitis with nail changes like pitting and onycholysis. Okay, and you won't get any subcutaneous nodules. Subcutaneous nodules are seen in rheumatoid arthritis. Okay, RA. Okay, DIP sparing arthritis is RA. Okay, now question number 28. 58-year-old more. So, what is the OCT finding in the diabetic macular edema? So, OCT shows hyper reflective dots in the outer nuclear layer. Okay, you get hyper reflective dots in the outer nuclear layer. Okay, so okay, now why is it not impending rhegmatosinus RD? Then would have shown SRF. SRF is subretinal fluid. Okay, active choroidal neovascularization would have seen in age-related macular dystrophy (ARMD). Okay, it has a different pattern, flower pattern. Now, early glaucomatous damage. Okay, it acts the nerve fiber layer. Okay, and not the outer nuclear layer. Okay. Now, question number 29. 58-year-old male with 20-year-old history of poorly controlled hyper. So, hypertensive retinopathy. What is the underlying pathology? The underlying pathology is vasospasm followed by sclerosis and hyalinization of the arteriolar valves. Okay, what happens? There is vasospasm, then there is structural changes, then you have advanced damage. In structural changes pattern, you will get hyaline arteriosclerosis, vessel wall thickening and all. And in advanced damage, you will get the AV nicking and the cotton wool spots and all. Okay, now question number 30. What does 30 say? 3-day-old neonate. Okay, now they are asking. Uh, okay, so you are giving sodium benzoate for hyperammonemia. Okay, so what does sodium benzoate do? It conjugates with glycine to form hippurate. Okay, it conjugates with glycine to form hippurate and thus provides an alternate pathway for nitrogen excretion. Okay, so that is what happens. Okay, now question number 31. Okay, so what do you see? In 31, you have a child with leukocoria. Okay, or so white eye reflex and orbital scans are shown. Okay, now what does you see? See, so you see a intraocular mass with, you can see, normally you see calcifications. Here also mild calcifications are seen. See, okay, mild calcifications are seen. So unless proven otherwise, leukocoria in a child mark for retinoblastoma. RV. Okay. Now question number 32. In a simple muscle. Okay. So here also, okay, kindly read the question. So it's a very important. So there is in latent period. Okay, so latent period is actually the delay between the stimulus and the visible contraction. Okay, that is called the latent period. Okay. Okay, so here both the assertion and reason are true and are the correct explanation. Now, question number 33. Which of the following physiological transport process is an example for primary active transport? So, primary active transport directly uses ATP hydrolysis. Okay, so primary active transport directly uses ATP hydrolysis and it also moves ions against the concentration gradient. Okay, so what is here? Here you have the sarcoplasmic endoplasmic reticulum calcium ATPase pump, okay, which transports calcium from the cytosol to the sarcoplasmic reticulum, okay, and it uses the ATP directly, okay. So what has happened? Primary active transport there is sequestration of calcium. Okay, now GLUT1, it is facilitated diffusion. Okay, GLUT1 is actually facilitated diffusion. Okay, co-transport of sodium glucose into the intestine is by, okay, sodium glucose co-transport. It is a example for secondary active transport. Okay, it is an example for secondary active transport. And movements of water is via aquaporin. It is no ATP required. Okay, now we move on to question number 34. So, highest level of evidence decision making discussed in the previous GT, it is a meta analysis. Okay, now question number 35. Okay, this concept is also discussed in the daily challenge test series, where we say what is the most appropriate and feasible setting, okay, for pap smear. Okay, like it is like not pap for detecting HPV. Okay, in a low resource setting. So you have a low resource setting where you need to should have a single visit screen and treat technique. So they are asking for a single visit screen and treat. Okay, so you use VIA. Okay, okay, because it is a cheap technique and lower resource settings you can use it. Also, same day treatment can be used because PAP requires a pathologist. Na? You need to PAP and Nicola staining and all should be done. Okay. Now, question number 36. Okay. What does they say? Farmer brought to the emergency department. Okay. So, contaminated traumatic wound of a farmer. Okay. So, when you have a deep contaminated wound, okay, and there has been thorough debridement already done. Now, what is a subsequent step in management? So you just pack the wound in a saline soaked gauze and you do a delayed primary closure. Okay, you do a delayed primary closure. Why do you do a delayed primary closure? Because it is a dirty or contaminated traumatic wound. Okay, so irrigation followed by debridement, followed by debridement, should be followed by delayed primary closure. That is how we should do. Okay, because we need to always monitor for infection and reduce the bacterial load. Okay, now question number 37. 37 asks what is the maximum conductive hearing loss? Okay, or the maximum airborne gap with normal bone conduction. So that is 60 decibels. Okay, fact based question. Okay, now question number 38. Okay, as a physician, what is the most okay? So screening first degree relatives of a diabetic or a hypertensive patient. Okay, so now you are asked what to advise his relatives. Why you are doing a family based risk stratification plus opportunistic screening. Okay, you're doing a family based risk stratification with opportunistic screening. Why? Because both of the diabetes as well as hypertension have a high genetic predisposition and shared lifestyle risk factors. Okay, so what is recommended? You advise periodic screening for both diabetes and hypertension for the all adult. So first option is if they become symptomatic. No, why wait for that too much time? Mostly it is silent. Okay. Second one is comprehensive genetic panel. No, no, it is polygenic. Okay. Counsel them on no. So they are telling delayed screening. No, you should do early screening. Okay. Now question number 39. Okay. So you have a pediatric ALL. Okay. You have a pediatric ALL. Okay. Now they are asking what is the marker for B cell lineage? Okay, the marker for B cell lineage is CD19. Okay, so what are the B cell lineage marker? It is CD10, CD19, CD20. Okay, CD9, CD10 is also called as colon. Okay, CLL associated marker. Okay, more specific is actually CD19. Okay, MPO is a marker of AML. TDT is a marker of ALL, but for both B and TL. Okay. Now CD3 is a marker of T cell. Okay. Now question number 40. Okay. Match the precursor amino acid. Okay. So the amino acid tryptophan is from serotonin. Okay. Tyrosine is from dopamine. Okay. Arginine is from NO. Okay. Histidine is from histamine. Okay. So it is A3, B4, C1, D2. Okay. Now, question number 41. So, what are they asking? They are asking which of the following antifungal. So, mechanism of action of antifungal. Okay. So, fungal lucide tRNA synthetase. Okay. It is by the tavabarol. Okay. We have discussed this question in our daily challenge. So, caspofungin, it is inhibition of beta 1,3-glucan synthesis. Now, voriconazole, it is a triazole antifungal. So it inhibits the ergosterol synthesis. Okay. And griseofulvin, it inhibits the mitosis. It inhibits mitosis or it binds to microtubules. Okay. That's it. Now, only antifungal that blocks the protein synthesis via tRNA synthetase is actually tavobarol. Okay. Now, question number 42. Okay. 40-year-old. Now they are asking Carhart's notch. Okay. You had identify the false statement. Okay. So the false statement is it indicates reversible cochlear damage. Okay. So Carhart's notch is a pseudo sensory neural dip in the bone conduction seen in autosclerosis. Okay, at 2000 kilohertz, 2 kilohertz. Whereas in noise induced hearing loss, you get a dip in 4 kilohertz. Okay, why do you get Carhart's notch? It is due to stapes fixation. Okay, it improves after stepidotomy. It is a pseudo sensory neural phenomenon as it mimics the SNHL and it has a reduced mid frequency resonance. Okay. So there is no toxic mediated damage and all in of autosclerosis. It is actually the mechanical fixation. Okay, it is irreversible. No, it is not. It is a reversible change because after the repair, okay, after you repair the disease, it changes. Okay, that is wrong, and it is not toxic metabolite. Okay, now question number 43. So treatment of AF. Okay. So they are asking the digoxin toxicity duration after stopping the drug. Okay. So you get a classical yellow green halos and all. Okay, so this is actually digoxin toxicity. So we have discussed that it has a narrow therapeutic index. Okay. Because digoxin has a long T half. Okay. And the patient has a impaired renal function. It will last for more than that. Okay, so it lasts for 4 to 6 days. Normal T half is actually 3 to 4 days. 3 to 4 days. Now, question number 44. Okay, young woman presents with. Okay, so what is this? So it is a history of autosclerosis, and they are showing a stapes prosthesis. Okay, now TORP and PORPAR or total ossicular replacement process and partial ossicular replacement processes. Okay, it is used when all the TORP is used when malleus, incus, stapes all are absent, and PORP is used when stapes suprastructure is intact but malleus or incus is damaged. Okay, now 45. Okay, so now there is a okay, which of the statement are correct? Now they are telling standard therapy costs us 50,000 and effectiveness is 2 QALYs. New therapy is just 90,000 and effectiveness is 3 QALYs. The WTP or the willingness to pay threshold is 40,000 per QALY. So first they are asking us to calculate ICER. So ICER is given by the formula. Sorry. So ICER is given by the formula. It is given by C2 minus C1 by E2 minus E1. That is, what is E? It is E is the effectiveness or the quality. So cost, that is 40,000. 90 minus 50K by 3 minus 2. So ICER is 40,000. Now compare with WTP. ICER is equal to the WTP. That means it is a cost effective thing. Okay. So that is it. So 1, 2. That is 3 and 4. Okay. It's a cost effectiveness analysis. Now, moving on to the next question, 46, where, okay, so they are telling Okay, so rheumatic fever with carditis. What is the diagnostic criteria? So the diagnostic criteria is actually NADA's criteria. Okay, okay. Duke's criteria is for infective endocarditis. Kawasaki criteria is for Kawasaki disease, and Jones criteria is for rheumatic fever. Okay, but why is it NADA's criteria? Because here the child presents with only carditis as the major manifestation. Okay, so you can't go for Dr. Jones criteria. Okay, okay. So that is the twist here. Okay, now 47. So you have true love. Okay, and which criteria? True love and which criteria for ulcerative colitis? Okay, so severe disease. What is the criteria for severe disease? The criteria for severe disease is when you have pulse more than or equal to 6 bloody stools per day plus pulse rate more than 90, temperature more than 37.8, HB less than 10.5, and ESR more than 30. Okay, that is severity. Okay, so it is A, B, and D. Okay, now question number 48. What does 48 say? So, a microbiologist is there is a partially acid fast filamentous organism. Okay, there is a filamentous branching gram positive rod, which is a weak AFB. So, diagnosis actually it is a nocardia. No, why do you get partial acid fastness? Because it is due to the presence of mycolic acid. Okay, and this short or intermediate. Okay, that is why you get a weak acid fasting. Okay, now question number 49. In a patient with absolute insulin deficiency, okay, all of the following are true regarding the changes. So you are asked to find the false statement. Okay, the correct answer here is HSL is activated by dephosphorylation. Okay, in so what is the true physiology in type 1 diabetes? There is hormone sensitive lipase, okay, which is phosphorylated and activated. HSL is phosphorylated and activated because there is increased CAMP and there is increased lipolysis. Okay, so it is activation by phosphorylation. HSL by phosphorylation. Okay, very important. Okay, this concept is very important. Okay, okay, via PK. Okay, now that's it. Now, last question 50. Okay, what does they say? Set one last question. So, 22-year-old woman. So, there is a cardiac myxoma, lentigine, recurrent tumors. Okay, what is this? This is a Carney complex. This is Carney complex. Okay, it is a classical multiple endocrine neoplastic syndrome. Okay, with cardiac myxoma, skin pigmentation, cutaneous myxomas, and endocrine tumors. Okay, it is due to TRKAR1A Okay, in leopard syndrome, you get similar lentigines, but there is no cardiac myxomas. In Poojagar, you get hamartomatous GI polyps with mucocutaneous pigmentation. In Noonan syndrome, you get short stature with pulmonary stenosis. Okay, there is no lentigines or myxomas. Okay, so that's it. Section 1 is done. Now we'll be back in section 2. Okay, thank you. Okay, so we'll start. So, section 2, question number 1. A 40-year-old scuba diver is called to the emergency department after a rapid ascent from a 30-meter dive. He complains of severe deep pain in his knees and shoulders, and he is tachycardic and hypotensive. Um, his trunk displays the skin finding shown in the image. Now they are asking what is the most findings is most consistent with the primary hemodynamic change in this condition. So what is this condition? This condition is classically it is the decompression sickness because it is a diver. Okay, so decompression sickness. Okay, so diver who is having a rapid ascent. That is the key in the question. Okay, and there is evidence of shock. Why? Because there is tachycardia and hypotension. Okay, now what does Henry's law say? Henry's law says that high pressure underwater, the nitrogen dissolves in the blood and the rapid ascent will lead to decrease in the pressure. Okay, because of this decrease in pressure, the nitrogen bubbles will be formed. Okay, because there is high pressure underwater, nitrogen will get dissolved in the blood, and because of the rapid ascent that happens, okay, there will be decrease in pressure, and the nitrogen bubbles will be formed. What will these bubbles do? They will cause vascular obstruction. They will cause endothelial injury. They will cause plasma leakage. So, in general, what does it cause? It leads to hemo concentration. Now, will hemo concentration cause what to say? Increased hematocrit? Yes. What happens as the plasma leaks, RBC concentration increases, and hence the primary hemodynamic change here is the increase in hematocrit. Okay, that is HCP. Okay, does thrombocytopenia happen? Yes, but will occur late in the reaction. It's not the primary hemodynamic change. Is there any destruction in the WBCs? Nothing is happening. The stress usually causes leukocytosis and prolonged PT. No, it is not seen in liver disease. Okay, it is not seen in decompression sickness. It is seen in the liver disease, DIC patients, etc. Okay, so what are the different things? When you have joint pain, it is due to bends. When you have chokes, it is due to pulmonary involvement. What do you see in skin? It is cutis marmorata. What do you see in CNS? Because there is severe CNS involvement with shock. Okay, so causes nitrogen bubbles. The basic concept is induced law. The treatment will be hyperbaric oxygen therapy, and in hemodynamics there will be elevated temperature. Okay, I hope this question is clear. Okay, now moving on to question number 2. So they say a 25-year-old farmer spotted the emergency department after an alleged suicidal injection after after an alleged suicidal injection of a rodenticide. So they are telling rodenticide poison and with the features that is what are the features given? It is a garlic, it has a garlic odor with a luminescent vomitus of chores. This is classical of white phosphorus. Okay, it is classical of white phosphorus poison. And white phosphorus is a highly lipid soluble substance, highly lipid soluble, and so it is rapidly absorbed. What are the side effects or what are the toxic effects? It causes hepatic necrosis as well as multi-organ failure. Now, what is the mechanism of treatment here? So, gastric lavage uses oxidizing agents like potassium permanganate and copper sulfate. But copper sulfate is actually historical. What does they convert? They convert the phosphorus into non-absorbable form. forms or non-absorbable compounds which forms insoluble precipitate. Okay, and thus it will be a less absorbable form, and there will be limitation in the systemic toxicity of the drug. I mean, white phosphorus. Okay, they will act as a competitive antagonist of muscarinic receptors. No, that happens in OP poison, where you give atropine. They chelates the toxic supplement, forming a water soluble complex. No, chelation and all occurs. That is, you give British antidote, BAL. So BAL is given for MAL, mercury, arsenic, lead. Okay. Now, reactivates acetylcholinesterase by cleaving its bond with the poison. No, that is the ideal mechanism of action of oxines, pralidoxine. Okay. So that's it. Okay. Now, question number three. What does question number three say? If a 52-year-old patient involved in an RTA is brought to the emergency department, CT scan shows a base of skull fracture, and patient has an isolated paralysis of the left lateral rectus muscle. Okay, resulting in inability to abduct the eye. The fracture, so they are asking what is the cause of the nerve. Okay, LR6 SO4 thrice. So LR6. What is the supply of lateral rectus? It is abducens nerve or the cranial nerve 6. Okay. Origin is at pons 5, 3, 4, 5, 6, 7, 8. Okay. 8 is in the contour. Okay. 3, 4, 5 in the midbrain. Okay. And it traverses through the superior orbital fissure. Okay, enters into orbit and supplies the lateral. Okay, what all does superior orbital fissure transmit? It transmits 3, 4, 6, and B1. Okay, 3, 4, 6, and B1. What does foramen rotundum transmit? It transmits the maxillary trauma. Okay, maxillary it's V2. Okay. What does foramen ovale transmit? It transmits the except from the not I'm not telling all the sectors. Nail. Okay, mandibular nerve, axillary artery, the lateral emissary veins and all. Okay, so V3. Okay, foramen ovale is ovale through the foramen ovale, mandibular nerve traverses. And then we have optic canal. Optic canal transfers the optic nerve and the ophthalmic artery. Optic nerve and ophthalmic artery. Okay, that is. So, what if they ask? When you have a cavernous sinus lesion, which is the first affected nerve, it will be abducens nerve. If there is a diabetic neuropathy, which is the first affected nerve, again, it will be the abducens nerve. Okay, so CL6 palsy will lead to medial deviation because there is absolute unopposed action by the medial rectus. Okay, that's it. Now, question number 4. What does question number 4 say? Okay, 45-year-old farmer. Okay, now they are telling uh, there is an exposure to a green fumigant which has a garlic or fishy odor, which causes severe hypotension and metabolic acidosis. What is the poison? It is aluminum phosphide. What does it causes? It releases the phosphine gas. Okay, it releases phosphine gas. Okay, what does it does? What does it do? I'm sorry. Okay, it does mitochondrial poisoning. It's a mitochondrial poison. It causes free radical injury and it also causes severe myocardial depression. Okay, and what does it lead to? It leads to refractory shocks, arrhythmias. Okay, so what do you give? Why do you give Maxel? Even in hyperkalemia, okay, there are magnesium stabilizers, and there are membrane stabilizers, there are shifters. Okay, there are different drugs that act here. So here, Maxwell acts as a membrane stabilizer as well as an anti-arrhythmic drug and an antioxidant drug. Okay, because it protects the myocardium, it prevents the fatal arrhythmias and it widely used as a supportive therapy. So Maxwell acts as a membrane stabilizer. Okay. Now, cytochrome oxidase inhibition and all the same cyanide poison. Okay. Catharsis, there is no role in the mechanism. Okay. So always remember, biphosphorus causes liver failure. Okay. Organophosphate causes coronary crisis. Aluminum phosphide causes severe refractory shock. Okay. That's it. Now, question number five. What does question number five say? A 28-year-old male is brought to the trauma. So it is this basic ATLS launch. Okay. Now, after initial stabilization, what is the next step? Here you see that the patient is hemodynamically stable after giving IV fluids and EFAST is negative. There is altered syndrome. Okay. Core concept is the first you go for primary survey ABCD, then resuscitation, then reassess the stability. Once stable, you go for definitive image. So what is the next imaging here? Do a whole body contrast enhanced CT scan. Okay, we call it a pan scan. Okay. To do a whole body scan. Okay, that's it. Now, question number six. Okay. So, question number six, you have a post-gastrectomy patient with pins and needle sensation, with a pallor, a smooth red tongue, and decreased vibration and efficiency. So, you have a patient with a post-gastrectomy with some kind of neurological deficit. Okay. Is it iron deficiency? So, post-gastrectomy, we'd always think about iron deficiency anemia, B12 deficiency anemia, because the iron absorption takes place in the duodenum, whereas the B9 B12 occurs in the predominantly takes place in the ileum. And post the gastrectomy, what happens? So that is the next question, the next thing that we need to ask in our mind. When we look at the question, we see that the HB is 8 with MCV is 118. The normal value of MCV is actually around 76 to 96. So it is a macrocytic anemia. Okay, so it is a macrocytic anemia. Okay. So we have a macrocytic anemia with the tingling in the center. So it is essentially it is B12 deficiency anemia. And what is primary pathological mechanism in the B12 deficiency anemia? It is lack of intrinsic factor production. And what happens when there is a posterior column tract, when there is a medial efficiency anemia in the spinal cord? What happens in the spinal cord? There is demyelination. And it leads to subacute combined degeneration, which leads to posterolateral cord syndrome, where you get the posterior cord as well as the lateral corticospinal tract of the pyramidal tractors. Okay. Now, question number seven, very easy. So they have given Z score is minus 2.5. Now, weight for height, Z score is minus 2.5. What do you want? It is less than minus 3. Okay, and you can see 50 period edema. Okay, and if you see, you go to the mid upper arm circumference, it will be less than 3.5. And this is nothing but sand. Okay, now question number 8. Now, the neurologist is assessing what? What is he assessing? He's assessing the integrity of the dorsal column. Okay, so dorsal column of the medial lemniscal pathway. Now they are asking what is the okay, 2-point discrimination. So for 2-point discrimination, he is asking the receptor. Which receptor is there? So you need a slow acting receptor which gives fine touch plus static pressure with high spatial acuity. Okay. And what is the classical receptor that provides all this? Synapse. Another point we need to know is it is also used in brain. Okay. Now, what about nuisance corpus? It is a rapidly adapting receptor. Okay, it is a rapidly adapting receptor. It is for light touch. Again, Cassinian corpuscles, again, it is a very rapidly adapting. And it is used for deep vibration. Okay. And what about Raffinis? Raffinis available is used to detect skin strips. That's it. Question number 9. A 48-year-old patient. Okay. Presents with a 15-year history of. Okay. So there is a long-standing Raynaud's dysphagia, tight skin, classical of limited systemic sclerosis. Okay. Limited SSC or Crest syndrome. Okay. And they are asking what is the autoantibody. And the autoantibody is anti-centromere A. Where they get anti-SCF anti, you get it diffuse system. So it's called a stop on isomerase 1. Okay. Anti-DS1, DS-DNA antibody is in SL. Anti-Jo1 is in polymorphisms. Okay. Question number 10. Now they are asking a 38-year-old woman attending genetic counseling. So there is the key question is when does the oocyte meiotic arrest occur? So oocytes are formed before birth and they remain paused for years. Okay. Risk of non-distension will increase with the maternal age. So what do they ask? When do the primary oocyte get arrested? It gets arrested in the diploting stage of the prophase 1. Okay. This, I think 12th standard student should answer this question. Okay, because it's given the NCR. Okay. The fetal life, the oogonia, which forms the primary oocytes, enter the meiosis one and they get arrested at the diplotin or the dictyotin stage. Whereas from puberty till ovulation, one oocyte resumes meiosis one and completes it and forms the secondary oocyte. Whereas the secondary oocytes gets arrested at the metaphase 2 and completes meiosis only after fertilization. Okay, hope that's clear. Now, question number 11. Very easy. Hostel outbreak with jaundice. Okay, there is a cluster of cases with low grade fever, nausea, and jaundice. So, when you have a patient with fever, anorexia, no, vomiting, okay, fever, anorexia, vomiting, in the background of the jaundice, always think about hepatitis. Okay, so here you have a contaminated water source. It is the well after the flood. Okay. And it is a self-limiting illness. Okay. So what is the most likely virus? Is hepatitis A. Hep A. You don't know. Outbreak. So it is very, very easy to get. If it was hepatitis B, it's also fecal, but it will be more common in pregnant women and it will be a very severe disease. Okay. So in large epidemics or pregnancy, think about hepatitis C. Okay. Okay. Now, question number 12. So there is a history of progressive dysphagia plus regurgitation of undigested food. And the dysphagia is special. It is initially for salts and then for liquids. Okay. So what is the most likely diagnosis? The most likely diagnosis is Zenker's diabetes. What is the mechanism? There is incoordination plus the spasm of the cricopharyngeal muscle. There is upper esophageal sphincter relaxes. Pain. Okay, there is upper esophageal sphincter relaxation failure. Okay, there will be increased pressure leading to mucosal herniation in the Killen sections and thus a pouch is formed where the food gets trapped. Okay. Now, if it was diffuse esophageal spasm, the dysphagia, chest pain, and all would be intermittent and not progressive. And there won't be any regurgitation of the old food. Okay. If it is a traction diverticulum, it will be by some external factors like TV lymph nodes, which occurs in the mid esophagus. Okay. The traction occurs in the mid esophagus, and there is no food regurgitation. If it was an incompetent LES, then it is nothing but GERD, gastroesophageal reflux disease. Okay, so whenever you think about old food coming back, always think about vinegar sauce. Okay, now question number 13. Okay, the 10-year-old boy of African descent is brought to the emergency. Okay, now this classical sickle cell anemia. Okay, sickle cell disease. Okay. What is happening? There is a substitution inhibition of the glutamic acid by valine in the sixth position of the beta globin chain of human. Okay, just and then the of beta globin chain of hemoglobin, where glutamic acid was replaced by valine. Now, question number 14. Couple is undergoing genetic counseling for mitochondrial disorder. Okay, which is the correct anatomical basis for exclusively maternal inheritance in mitochondrial DNA. Okay, okay. So now they are telling mitochondrial inheritance. Okay, what does it happen? The disease gets passed from mother to all children, and the father does not transfer the disease. Why the only maternal transmission? Because the sperm contributes only the nuclear DNA, whereas ovum contributes the cytoplasm and the mitochondrial DNA. Okay, so only mother passes the mitochondrial diseases. Okay, what are the key features? This maternal transmission. Affected mother will give it to all children. Affected father will give no transmission. And there is variability due to heteroplasmy. What are the examples for mitochondrial inheritance? Leber hereditary property, male as MERR. Okay, so why is it due to? This is with mother's mitochondria. Now, question number 50, anemia Bharat strategy. We have discussed this elaborately in the range of time. We go and read this. Okay. Now, question number 16. What does question number 16 say? So, assertion reason type question. Okay. So, assertion reason type question, where you say esophageal carcinoma. Okay. So esophageal carcinoma, the characteristic, what is the characteristic initial symptom is progressive dysphagia. Okay. Okay. So this is actually easy because what is the mechanism? This both are true and explanation of A. Now, question number 17. So they are asking um, AJCC classification. AJCC T states. Okay. Okay. So they are asking the primary T state approach. Okay. Okay. So when you have a buccal mucosal carcinoma, okay, what is the T staging? So how does it? T1 is less than 2 centimeter. T2 is 2 to 4 centimeter. T3 is more than 4 centimeter. Okay. T4A, it is a moderately advanced local disease where there is skin involvement, cortical. So when there is skin involvement, skin involvement. So you know the grading is less than 2, more than 2, but less than or equal to 4, more than 4. T1, T2, T3. Okay. T4A is moderately advanced local disease with the skin involvement, cortical bone involvement, or deep muscles, or the extrinsic muscles of family involvement. And there is maxillary sinus involvement. Okay. So here the patient has skin involvement. So it will be T4A. But when would I win the answer T4B? T4B, if it was a very advanced disease, like there is masticated space, or there is involvement of the pterygoid plates, or there is involvement of the skull base, or there is encasement of the carotid artery. In all these cases, there would have been classical T4B status, T4A. Okay. Now, question number 18. A 58-year-old woman. This topic is okay. Now, there is a breast carcinoma. Now they are asking for a AJCC pathologic stadium. The tumor size is 6.2 centimeters. So it becomes T3. Okay. Now, then they are telling there are, yeah, 7 nodes. Okay. 7 nodes means this 4 to 9 nodes, it becomes N2. Now they are asking, there is no skin ulceration, there is no, no stitch, just one invasion. So it is not E4. Okay. Now they are asking, there is no distant metastasis. So it is N0. So it is a P3, N2, N0. Okay. To know the end statement, 1 to 3 N1, 4 to 9 N2 more than equal to 10 N3 with infracharacter more than 1. Okay. So P3, P into N0 is actually 3A. What would have been 3B? 3B would have been P4 tumor. Okay. What would have been 3C? Okay. 3C would have been N3. Okay. That's it. Now, question number 19. Okay, so you have a pressure ulcer. So it's a sacral ulcer with a partial thickness of the dermis involved. So what will be the stage B? Stage one is actually there is a breach in the there is non-glancing erythema. Okay, the type two is there is a partial thickness of the thickness injury where epidermis and dermis is in there. Type three subcutaneous tissue up to subcutaneous tissue it is visible. Type four is there is visible muscle, bone, ligament, tendon, or a joint. Okay. So, what is the management of stage two pressure ulcer? It is hyperthyroid. Yes. Stage two pressure ulcer. NPUA, that is National Pressure Ulcer Advisory Panel. Okay. Calcium arginate would cause a heavy exudate, and wet to dry gauze and all is for debridement. Okay. Enzymatic tissues and all we give it for necrotic tissue. Now, there are next questions. Which of the following structures is primarily developed from the hypoblast? So hypoblast forms the yolk sac and not the embryo prop. Okay. It forms the yolk sac, okay, not the embryo prop. Okay, so ectodermis from the epiblast, endodermis from the epiblast, mesodermis from epiblast. Okay, so epiblast is from the embryo, hypoblast forms the support or the yolk sac. Okay, that's yeah. Question number 21. So 21 says there is a 5-week old child with a neonatal cholestasis. Okay. We have discussed this question. Okay. In the daily chance. So there is a persistent jaundice after 2 weeks. There is a colic that is pale stools with the dark urine. Okay. A high DGT, elevated direct bilirubin. So it is biliary ataxia. Atresia. So I have that biliary atresia. Why is it not idiopathic neonatal hepatitis then doesn't cause pigment obstructions? Why is it not alpha 1 antitrypsin C? It would have been a less severe obstruction. And why is it not cystic fibrosis associated with liver disease? The presentation would have been in the later. Now, question number 22. Ovarian cyst of 6 centimeter in the pregnancy with no solid, okay, or no vascularity. What do? You do surgery only when if it is 8 to 10 centimeters. Okay. Surgery only when more than equal to 8 less than. Okay. With suspicious features. Okay. And CA125 and all are obsolete in pregnancy. So you do a repeat USGA and all this. Okay. Now, question number 23. Now they say there is a PAPCA thyroid with a history of radiation, then 2.5 centimeter nodule, micro calcifications. What is the next step in management? It is total thyroidectomy. Why? Because radiation history means it is aggressive. So PAPCA thyroid, it can lead to mets also. So always give total thyroidectomy as the option. When you do hemipthyroidectomy for small low-risk tumors, and when you do a subtotal thyroidectomy, not done anymore. Sorry. Okay. Okay. Now, question number 24. So they are asking which is the junctional component which is responsible for the ionic coupling. So it is the intercalated list can be with the rapid electrical conduction. Okay. So it is usually gap junctions. Okay. So that's most of the are actually mechanicals. Okay. Facial appearance is for ankle, whereas high tension acts as a barrier. Question number 25. So what do you see here? What do you see here? You can see a fracture IT of right field. There is an intertrochanteric fracture of the female with the shortened external rotated limb communicated fracture, high energy trauma and all. What is the management? So the age of the patient is 40. So you go with DHS plus day rotation. Where do you do a hemiarthroplasty? You do it in a neck of finger fracture. Where do you do THR? Only when the age is high, when there is selective it's only. When you do a cancerous screw, you do it when there is an intracapsular fracture. Okay. Now, question number 26. Okay, so they are asking the boundaries of the Pasaros triangle using solving the Ellison surgery. Okay, so it is the triangle around the pancreatic head. It is also called as the gastrinoma hotspot, which is superiorly bound by the cystic duct and the IBD junction. It's inferiorly by the D2, D3, and the and medially by the neck of pancreas. So it's A2, D3, C. Okay. Now, question number 27. Now, they are asking there is a primary hyperparathyroidism patient, right? Calcium is 11.7, PTH is elevated 180. Okay. Normal is around 65, 60s. Okay. Now, USC and system we scan that it is negative, and the patient is fit for surgery. So, what will be the next step to do a bilateral neck exploration? Why do you go for a bilateral neck exploration? Okay, if it was minimal in invasive surgery, you need to localize the like what where is the swelling in the. So you because of non-localizability, we go for bilateral neck exploration. Okay, and CNAC also it is for non-surgical candidates, whereas venous sampling and all is done fairly, but it was not the first line. Now, question number 28. Now they are asking you. Okay, so similar question has been discussed in the daily challenge. So it is a fasciola hepatica infection. What are the clues? It's a sheep farmer with a raw water cress, eosinophilia, RQ with spatioliasis, and the treatment is triclabendazole. Okay, Trasiquental is for all groups except fasciola. All groups. So let's us. All food, all foods except facial. That is not fine. Okay. Even approach like that. When do you give albendazole? Specifically can be given. Ivermectin is given for pneumothorax. Now, question number 29. So, there is a carpenter with a history of falling a ladder onto the hand, and there is this extension and there is radial deviation, but the patient cannot extend the MCP joint. Okay, why do you lose the MCP joint extension? Because the finger extensors are lost, but extensor carpi radialis is preserved. That is why wrist extensor was preserved. Where do you get this palsy? You get the pain palsy, or you get inversions, not palsy. So in pain palsy, if it was radial nerve injury at the spinal group, the patient would have had wrist drop. Okay, if it was medial nerve involvement at the elbow, then there would have been problems with hand flexion. Okay, and AIN, it will be no, that won't be any sensor. Okay, sensation would have been gone. Okay, yeah, okay. So they are asking the quadruple marker test for trisomy 21 downstream. Okay, the quarters, the four markers are actually A, B, E, I. Let's see how I remember. So A is AFP, B is beta FCB, E is S thyroid, and I is inhibin A. Pape is examined the first time. So, the self-free legal DNA it's a non-invasive test. Inhibin generic is not specific. Okay? Inhibin can inhibit A, B, C, lipid. So, now, question number 31. So 31-year-old, 52-year-old male with a okay, so small distinct hyperfusion and not seen. Okay, they are seeing the XFO. So they are the diabetic retinopathy patient having micro and okay. Now, if it was dot and blot hemorrhages, that would be hypofluoris. Okay. If it had been cotton wool spot, it indicates ischemia and hard actually succeeding like pit deposit. Okay. Now, question number 32. Okay, there's a patient, ulcerative colitis. They're asking the mechanism of action. Short answer is ejaculation. Okay. So, in space is Janus. And so, ejaculation. When the patient has failed inputs in a go for an oral. Okay. So, okay. Infliximab is a TN alpha in IL-1 to 2 3 push the in. Okay. And integral inhibitors, it is all. Okay, that's question number 33. Barking cause strider, so it was actually crew. Okay, and the LTB, laryngo bronchitis, and the osteoarthritis is parainflammatory. Okay. Now, 34. There are some infant diarrhea with the metabolic acidosis. So the most common organism causing infant diarrhea is actually rotavirus. Okay, and we confuse watery diarrhea with non-bloody stools, with severe dehydration and metabolic acidosis. And what is the mechanism? There is something called as NSP4 toxin. Okay, no one specific. NSP4 toxin, which causes chloride separation. Okay, okay. When there is villus damage, there will be malabsorption. Okay, so what of the basic pathogenesis? There is villus damage and malabsorption, and when intermediate flow. Okay, if it was an invasion, okay, there would have been the first option. There would have been bloody diarrhea. If it was preformed toxic, then the patient would have had rapid vomiting. For any research campus that's created. Now, question number 35. Question number 35 is very easy. They're asking which vaccine is used in what? Please. 1C, 2, 3, 4. Okay. Now, question number 36. Okay. So it's a very important step here. Okay. Because malaria, cyanide poisoning, many dollar pollution. Okay. So what happens? Now, what is the primary advantage of using thick smear in malaria? Okay. Thick smear in malaria. Okay. So the primary advantage is there is like highly sensitive. When the RBCs get light, the parasites get concentrated, and there will be better detection when the parasite load is low. So that is why you will use a fixed bearing peripheral serum in an area with high specificity. When you want to identify species, you go for a TC. Okay, or you want to quantify the amount of malaria parasites. You want to look at the RBC morphologies. Okay, always go for TC. Now, question number 37. There is a fire victim with a lactic acidosis. So they are asking which of the following mechanism of the most likely toxin describes the molecular mechanism of the most likely toxin responsible for. So it is actually cyanide poisoning. Why is it cyanide poisoning? Because it is a fire exposure. There is severe lactic acidosis. There is high venous outflow. Okay, so it is actually cyanide. On how to sign it. We have discussed EPC. So EPC and the inhibitors we have discussed this multiple times in the daily terms. We coincide. So then it blocks it. Fe3, so it blocks the cytochrome. So basically the complex 4, CN, carbon monoxide, all blocks the complex 4. Complex 1 blockade is by rotin 1. Okay. Uncouplers, they increase the heat. Whereas ATP base block is by polygomers. Protein amobarbital. Okay. ATP synthesis polygons. Okay. Now there is a pheochromocytoma symptoms. What are the pheochromocytoma symptoms? There is episodic headache. There is severe the palpitations, and there is diaphoresis or generalized sweating. Okay. This is and then the history of past thyroidectomy, Marfanoid habitus, MMN, person mean to be person mean to be person mean to be and the mutations to be performed. Will be medullary thyroidcarcinoma, mucosal neuromas, pheochromocytoma with primary hyperparathyroidism. So without primary hyperparathyroidism, because primary hyperparathyroidism is seen meant to A. Okay, that's kindly go and read men and neon. Okay, now take it. Long-standing diabetic person with severe vision loss, most likely to be BX. Right? What is BX? Vitreous hemorrhage. And what is the management? It is sparse planning. Sparse planning. Now, question number 40. There is an autoimmune polyglandular syndrome person. Okay, because there are chronic candidiasis, hypocalcemia, family history with hypoparathyroidism, adrenal deficiency. So now they are asking which of the following autoimmune conditions least likely to be seen. So autoimmune polyglandular syndrome one has three C's. What are the three C's? It is candidiasis, calcium, low hypocalcemia, and cortex lesion, adrenal cortex. Okay. So lead susceptibility, type 1 types. Type 1 saying autoimmune 2. Okay. Now, question number 41. Now they are asking a mechanism of a glass injury. What is the mechanism of glass injury? There is a efficient transmission through the fluid, and thus it damages the gas containing organs. So basically, the blast damage occurs in the air tissue interfaces like lung, ears, gut, or okay. So solid organs are not affected mostly. It is the gaseous organs affected. Okay. So you can it's not the solid organ. It's the gases. Now, question number 42. Again, main case stinky hair disease. Suppose your copper ATP 7A mutation leading to reduced copper. That is reduced lysyl oxidase, which leads to weak collagen. Okay. There is a decreased level of tyrosinase because there is a stinky hair and they say ceruloplasmin levels are high. No, that is in B cells. Here, ceruloplasmin levels are low. Okay. Now, question number 43. Now, they are asking a status epilepticus drug, which is given. Which is the drug given? The drug after the IV, so IV drug, so can be phenytoin, phosphatidylcholine, etc. Levetiracetam. Okay, what is it? There is slowing cardiac condition on monitor. So it is the cardiac sodium channel blockade by the phosphatidylcholine. Okay, it causes the hypotension, arrhythmias, and all. Okay, so it is uh, neither GABA dependent because GABA dependent cells are drugs are the benzodiazepines. Okay, okay, that is a dose dependent cardiac suppression. Now, question number 44. Okay, there's a false hyperkalemia. Why could have been the false hyperkalemia? But either there would have been some hemolysis or there would have been some delayed processing. Okay, so that is actually due to ED2. Okay, now question number 45. Okay. So they're asking there is a false low HbA1c. What can be the causes? It could have been hemolysis. It could have been CKD or they reduced the RBC lifespan. Is it vitamins? No. It can interfere and cause RBC lifespan, but it is less rare. HbA1c method. Okay, HbA1c method is actually very accurate method. So if you do HbA1c, you get a perfect. Now, what is the marker for short tandem repeats? Okay, SCR marker. Okay, next is quantitative fluorescence PCR. QFPCR. Qualitative slow. And this can be used, but it will not be quantitative. Now, 47. A 2-day-old neonate with central cyanosis that versus now you have for reason. Okay. So it is a U-shaped heart. You can see that's a U-shaped heart. Okay, so there is a U-shaped heart. Now, what is it due to? It's due to neural muscle failure, migration failure. Okay, so it will lead to corner-frontal defects. Now, question number 48, which is the pancreatitis marker. So, first marker enzyme to lyse will be amylase. Okay, but lipase is more specific and it lasts long. So, it is which is wrong. It's not lipase. It's amylase. Yeah. 49. 49 regular ambu or a 40 supraglottic airways, which is incorrect. Okay. You can look at the insulin and identify it's a first generation element with more risk of aspiration. Okay. No, it is high risk of aspiration because there is no aspiration procedure. Okay. And there is no gastric tube channel. Okay. Gastric channel is present in second generation. Okay. Now, last question of the um, section 2. So, what they are asking an add-on lipid drug. So, what is an add-on lipid drug to this patient? Where there is a inhibition of NPC1L1 transporter, and that by this is everything. Okay. Why is it not evolocumab? It is a PCSK9 inhibitor. Okay. Why is it not bempedoic acid? It inhibits the cholesterol synthesis and fibrates inhibits the fights. Okay. When statins are not given enough, think about acetaminophen, then we add. Okay. That's it, guys. 50%. One hour, please. Thank you. So we are done with section 1 and section 2. Now we move on to the section 3. So a forensic team is investigating a sudden death. Okay, so these kind of long sum questions always start reading the last line. So they are asking which of the following poisons disrupts the electron transport chain at a different site. So they are asking complex 4 is given. You can see that just about the line above you there is complex 4 given. And then they are asking which disrupts the ETC at a different site. So complex 4 is inhibited by what all substances? It is the CN, the CO, the sodium azides. Okay, mostly the gases. Okay, the gases they inhibit the the gases inhibit the complex 4. Now they are asking which is the one poison which affects the ETC at a different site, and that is protanol. Okay, protanol, amobarbital. Okay, that's it. Okay, we have discussed the ETC toxin in our daily challenge. Okay, so you know that. Okay, type complex one is NADH coenzyme Q. Complex two is succinate to fumarate converting. Okay, FADH2 entry will be given. Complex three is CoQ cytochrome C, and the enzyme or the poison that affects is anti-mesyl A. Complex four is the cytochrome oxidase, where the inhibition is by CN, cyanide, CO, carbon monoxide, azide, and H2S, hydrogen sulfide. And then you have the ATP synthase where the inhibitor is the oligomers. Okay, that's it. Now, question number two. Question number two, they are asking a 12-year-old girl presents a history of recurrent oral thrush and fungal infections since childhood. Now, they are asking recurrent candidiasis and hypocalcemia. So, what is it? So, recurrent candidiasis, hypocalcemia, plus hyperphosphatemia, plus low para. Okay, so there is a classical history of hypoparathyroidism with the recurrent candidiasis, recurrent chronic or chronic mucocutaneous candidiasis. Now, this is classical of autoimmune, autoimmune polyglandular and polyendocrine syndrome. One, that is APS1. Okay, candidiasis, hypoparathyroidism, adrenal insufficiency, and other autoimmune features. Okay, it is CHA. So it is adrenal insufficiency, primary adrenal insufficiency. Okay, that's it. Now, so what is it? In APS1, that is candidiasis, hypoparathyroidism, Addison's. What do you see in APS2? It is Addison's plus thyroid disease plus type 2 diabetes, type 1 diabetes mellitus. Addison plus thyroid disease plus type 1 diabetes mellitus. Okay, that's it. Okay, okay. So APS1 is called as APS1 is due to AIRE mutation. AIRE mutation. APS2 is also called as Schmidt syndrome, and it has a polygenic inheritance. Okay, APS1 is in the childhood, whereas APS2 is in the adulthood. Okay, candidiasis, hypoparathyroidism are all hallmarks in type 1. Okay, now we'll move on to question number 3. So question number 3 says 16-year-old male with multiple comedones. Okay, so they are asking, where do you get? This is a history of acne vulgaris. So they're telling acne and which glands are affected. That is due to the blockage of the sebaceous glands. And the secretion mode of secretion is actually holocrine, where the entire cell degenerates and ruptures. Okay. In merocrine, it is actually exocytosis only. There is no cell loss. It is seen in the eccrine glands, the sweat glands, and the pancreas. Okay. Where do you get apocrine? Apocrine is when the apical part of the cell is pinched off. Seen in the apocrine sweat glands of axilla. Now, endocrine, hormones into the bloodstream. Okay. Now, question number four. Question number four is match the intracytoplasmic neuronal inclusions. So, Negri bodies is associated with rabies. Okay. Lewy body is seen in Parkinson. Lafora bodies are seen in progressive myoclonic epilepsy. Okay, which are glycogen-like inclusions. And Bunina bodies are seen in ALS, amyotrophic lateral sclerosis. So it is A3, B1, C4, and D2. Okay, now question number 5. 38-year-old male presents to the emergency department with a 4-hour history of severe colicky flank pain and the CT shows 7 stone at the VUJ junction, VUJ or the vesico-ureteric junction, and the vitals are stable and the patient is afebrile. So management always depends on the size of the stone, location of the stone, and the complications. So size, location, and complications are the core principles of managing a stone. Okay, so if the size is less than 5 mm, wait for spontaneous passage. If it is between 5 to 10 mm, then you do a medical expulsive therapy. And if it is 10 mm, you go for intervention. Okay, spontaneous passage, medical expulsive therapy, and intervention. Okay, so here it is a 7 mm stone, which is borderline, but still passable. And it is in the distal ureter. So it will pass easily. Okay, and the patient is stable. So you use a medical expulsive therapy with the tamsulosin. It is an alpha blocker and relaxes the ureter and helps the stone pass. TSW can be used for larger stones or when the met fails. Okay, URS is indicated if there is persistent occlusion or there is severe pain without any control over NSAIDs and failure of MAT. PCN is done when there is obstruction plus infection and there is chance of sepsis. Okay, if there is fever, never go for net. Okay, do decompression. Okay, that is it. Okay, now we move on to question number 6. What does question number 6 say? Okay, assertion reason. So this is about peripheral chemoreceptors. Assertion is the so what. Okay, so What does assertion say? A significant decrease in PaO2 is the most potent and unique stimulus for. Okay. The significant decrease in PaO2 is the most potent and unique stimulus for PCR. That is true because peripheral chemoreceptors, the carotid and the aortic bodies are especially sensitive to hypoxemia. Okay. Then they say uh, hypoxemia inhibits oxygen sensitive potassium channels. Okay. So, yeah, that is also true. What happens when there is hypoxemia? There will be decreased PaO2, which leads to closure of potassium channels, and there is membrane depolarization. There is calcium entry, which stimulates the neurotransmitter release and stimulates the afferent nerves, and there will be increase in ventilation. Okay, so the assertion and the reason are true, and both are the correct explanation. So always remember, peripheral chemoreceptors are located in the carotid and aortic bodies. Main stimulus is decrease in PaO2. Center is the then it is a fastly adapting receptors and mechanism is by potassium channel inhibition. Whereas central chemoreceptor are located in the medulla. Um, Main stimulus is hypercarbia, increase in carbon dioxide via decrease in pH, and it is lower onset, and CSF pH change is the primary mechanism. Okay, now question number 7. A junior resident in the surgical ward. Okay, so they are telling gauze and cotton swabs. They are soiled waste and goes into the yellow bag. Okay, what all goes into the yellow bag? Human anatomical waste, animal waste, soiled waste, blood, body fluids, contaminated items, all goes into the yellow bag. Okay. 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 Now, red bag is for contaminated recyclable plastics. Then the IV sets, catheters, tubing, rubber, recyclable, all going red. White is for sharps, blue is for glassware. Okay. Now, question number 8. Question number 8 is on skin and temperature regulation, where they say, uh, what is the mechanism of heat loss? Okay. So, when the heat transfer always depends upon the temperature gradient. Okay. So, radiation, conduction, convection, all happens when the body temperature is, so all happens when the body temperature is more than the environment. Whereas evaporation occurs independent of gradient. Okay, so there is heat gain and not loss. Okay, as the environment is hotter. Okay, so the only way to lose heat is sweat evaporation. Okay, that is, if environment is hotter than the body, only evaporation would work. Okay, that's it. Now, question number 9. What does 9 say? Now, heat exhaustion progressing to heat stroke. Okay. Now, the marathon runner hot and humid day, 39.8 degrees Celsius temperature, tachycardia, hypotension, and the patient has profuse sweating. Okay, but without any neurological symptoms. So, what is the most important indicator of progression? Okay, the most important indicator of progression is one is neurological symptoms like delirium, confusion, coma, and when the patient has dry and hot skin. Okay, okay, because these define the key features of heat stroke. Okay, so heat stroke setting is often absent after 40 degrees Celsius. Okay, so it is okay. The second option is profuse sweating. Yeah, that is seen in heat exhaustion. Muscle cramps. No, it is also seen. It is seen in heat cramps. Okay, which is a mild form. And postural dizziness and all seen in heat exhaustion. Okay. Now, question number 10. Okay. This is a very classical PYT, I should say. Okay. Pheochromocytoma. So, pheochromocytoma. Okay. They are asking what is the initial investigation? The initial investigation of choice would be plasma-free metanephrin. Okay, plasma-free metanephrin would be the initial investigation of choice. Okay, screening test. What will be the screening test? Screening test would be 24-hour urine VMA. Okay, and imaging will be MRI. And what will you see? You will see light bulb sign. Okay, you will see light bulb sign. Okay, that's it. Now, how will you manage? That is another question. Alpha followed by beta blockade. Okay, that is phenoxybenzamine, and then increase the dose gradually till postural hypotension develops. Okay, very important. Now, question number 11. 3-day old term neonate undergoes universal. So, they are asking OA pass. Okay, okay. The patient has passed away, okay, OA has passed, but there are high risk factors. What are the high risk factors present? One is hyperbilirubinemia, and then you have a family history of deafness. Okay, so a high risk baby with a hyperbilirubinemia and family history of deafness is there. So OAE always tests the OAE tests the outer hair cells. That is the cochlea. It does not test the one is the auditory nerve, and then is the brainstem pathway. Okay, these two are not tested by the OA. So a baby can have normal cochlea, that is OA pass, but abnormal neuron transmission, and that is called as auditory neuropathy spectrum disorder, ANSD. Okay, that is it. Okay, that is it. Okay, now question number 12. Okay, so they are asking. Okay, so this is a very favorite question. The structure is the pterion. So pterion is a junction of frontal, parietal, temporal, and sphenoid bones. Okay, it overlies the anterior branch of MCU. Okay, and the brain structure is the where does MCA run? MCA run in the lateral sulcus or the Sylvian fissure. Okay, so neurosurgical approach where pterion can access the insula, the MCA territory, and the Sylvian fissure region. Okay, central sulcus will be more posterior. It separates the frontal and separates the frontal and parietal lobes. So parieto-occipital subsulcus will be in the posterior brain, and calcarine sulcus, it is in the medial surface. Okay, occipital lobe. And pterion fracture will lead to PDH. Okay, there will be temporal region trauma, lucid interval will be present, and rapid deterioration. Okay, now question number 13. So they are asking you, which of the following Physiological changes would result in an increase in the GFR. Okay. So, so now always know that the net filtration pressure is given by the formula PC minus pi C plus pi B. Okay. Now, what is PC? It is the capillary hydrostatic pressure. The pi C is the capillary oncotic pressure. And pi B is the capillary, Bowman's capsule hydrostatic pressure. Okay, or the interstitial hydrostatic pressure. So, when will you get a okay, PGC, PC minus PB. Okay, I'm sorry. There is a small change. So it is PC minus PB minus that is capillary hydrostatic pressure of the glomerular membrane minus the capillary hydrostatic pressure of the Bowman's capsule. Okay, so this is of the Bowman's capsule. This is the oncotic pressure minus Bowman's capsule oncotic pressure. So this pi H or the PGC, it will push fluid out. Bowman's capsule hydrostatic pressure will push fluid in. Capillary oncotic pressure will pull fluid in. Bowman's oncotic pressure will pull fluid out. Okay. So anything that favors filtration or the movement out of capillary will increase the GFR. So it is increased oncotic pressure in the glomerular. Increased oncotic pressure in the Bowman's capsule. Okay. Now, if it was increased hydrostatic pressure in the Bowman's capsule, then it would have opposed the filtration. You see, it pushes in. If it was increased oncotic pressure in the glomerular capillary, it also pulls it in. Okay. So GFR will decrease. If it was constrictions of the afferent arteriole, then blood flow would have been decreased. So GFR decreases. Okay. That's it. Now, question number 14. A 45-year-old male presents progressive unilateral. I think we are a bit lagging. Okay. So they are telling a CP angle tumor. Okay. CP ankle tumor. We'll go fast. Okay. So they are talking about a CP ankle tumor with unilateral progressive hearing loss, tinnitus, well circumcised mass. So it is most likely to be a vestibular schwannoma. It is a benign encapsulated tumor. So it is an encapsulated tumor, benign encapsulated tumor, which are S100 positive. Okay. Schwannoma is associated with NF2 and neurofibroma is associated with NF1. Okay. It infiltrates and entraps axon. No, that is happening. That is true for neurofibroma. It is an unencapsulated tumor with the NF1. No, it is NF2. Okay. Frequent malignant transformation. No, they are benign. Okay. Now, question number 15. Okay, we did a similar question yesterday, or like in the section 2 also. Now cavernous sinus involvement, first nerve affected is will be abduction nerve because it is inside the sinus. Okay, whereas auto is outer. Outer. What is auto? Auto is ophthalmic. Three. I mean, sorry. Oculomotor, that is three. Then you have the trochlea, that is four. Then you have the ophthalmic, that is V1, and you have the maxillary, which is V2. This is auto. Okay, so auto in lateral wall, whereas inside the sinus, you have the abducens nerve and the internal carotid artery. Now, question number 16. Okay, so hip position plus fracture pattern. So now they are telling there is father. What is father? Flexion, adduction, internal rotation. So if there is father, it means there is posterior dislocation of the hip. If it was anterior, it would have been Faber. What is Faber? Flexion, abduction, external rotation. Okay, so there is posterior dislocation, and CT shows there is okay. What do you see in CT? You see a femoral head plus acetabular fragment. So it is a chevalet fracture. Okay. Now, Malgame fracture would be a pelvic ring injury. Pipkin fracture is fracture of the femoral head. Okay. Chevalet is fractal dislocation pattern of the hip. And Duvernay is actually isolated iliac wing fracture. Okay. When do you get this posterior dislocation? Usually, and there is a dashboard injury. Now, question number 17. There is a food processing company which produces HFCS, high fructose corn syrup. That is, it converts glucose to fructose using immobilized microbial cells. So, glucose converting to fructose. This is actually a isomerization. So, that is a aldose sugar is converted to a ketose sugar. And this is by glucose isomerase enzyme. Okay. Phosphomanose isomerase converts. Sorry. It converts mannose to fructose 6 phosphate. Triose phosphate isomerase converts, it is a 3 carbon atom conversion. So DHAP is converted to glyceraldehyde 3-phosphate. Okay. And peptidyl prolyl isomerase is protein folding enzyme. Okay. Now question number 18. Question number 18. They are asking, what is the role of malachite green in LJ medium? So LJ medium, the malachite green acts as an inhibitory agent. LJ medium is actually a selective medium. Okay. Okay. LJ medium is a selective medium. Okay. Now we move on to question number 19. What does it say? Uh, high anion gap metabolic acidosis is there. HAGMA. How did you identify? Anion gap is equal to sodium minus chloride plus bicarb. That is 138 minus 105, which is equal to 33. Okay. So, you know, high anion gap metabolic acidosis, it is MAT5s. What are the causes? Methanol, uremia, decay, then you have propylene glycol, isonic acid, also in iron. Okay. Then lactic acidosis, ethylene glycol, yeah, salicylates. Why is it not methanol poison? I mean, why is it not decay? Because glucose is 95. Why is it not severe diarrhea? Because there is no history of any diarrhea. Why that diarrhea occurs in normal and metabolic process. If it was alcohol, binge, and confusion, the most likely thing is toxic alcoholism. Okay, that's it. Now, question number 20. So, 20 says an axial medium structure tumor. Okay, what is the structure given? The structure is of a notochord. Okay, it acts as a primary organizer and induces the formation of the neural tube. Okay, now they are asking, what is the persistence of the notochordal remnants? Persistence of notochordal remnants will lead to chordoma. Okay, now, chordoma is a rare malignant tumor arising from the notochord remnants at the sacrococcygeal region or the clivus, the base of skull. Now, why is it not sacrococcygeal teratoma? It is from the totipotent primitive streak cells. Neuroblastoma is from the neural crest cells. And Williams tumor is from the metanephric blasts or the kidney. Okay. Now, moving on to question number 21. Question number 21 is pretty clear, like very straightforward. Hops on 1 foot, it is the gross motor. Copies a square is fine motor. Comprehensible story is language. And cooperative play is social, history, or emotional. Okay. Parallel play is in a toddler of 2 to 3 years, and cooperative play is in a preschool child, 4+ years. Okay. Very important. Okay, so it's 1C, 2A, 3D, 4B. Now, question number 22. Public health and so okay. So UHC has three matching. UHC cube is there. It has three dimensions. One is the population coverage. Okay, that is who is covered. Then service coverage, what services are covered, and financial protection, how much cost is covered. Okay, so if you match this sentence, it will be A1, B2, C3, D2. Okay, A1. Okay, now next question, 23. So they are asking most appropriate initial management in a case of intermittent claudication. So you have a case of intermittent claudication. Okay, it is a peripheral occlusive vascular disease. POVD. That is peripheral occlusive vascular disease. So you go for a ABPI, ankle brachial pressure index. ABPI, ankle brachial pressure index. Okay. What is the critical value? Critical value is less than point critical. Less than zero point 0.4 is severe ischemia. Okay. Zero point 0.9 to 1.0 is borderline, and more 1.0 to 1.4 is normal. Okay. Now, question number 24. Okay. The image provides an endoscopic view of the lateral meniscus. So now they are asking, this is the posterior end of inferior turbinate. Now they are asking the structure found postero superior to it. So it is actually the pharyngeal opening of the eustachian tube. Okay. Now pharyngeal tonsils will be in the roof of the posterior wall. And and fossa Rosenmuller lies posterior to the eustachian tube opening, and pharyngeal opening of eustachian tube is the answer. Sphenoidal sinus ostium. So it opens into the sphenoethmoidal recess. Okay, that's it. Now, question number 25. Question number 25 says, as per the latest PALS, pediatric active life support, or the pediatric BLS. Oh, because they are asking PALS, not PALS, pediatric BLS. Okay. BLS, what is the compression depth? Okay. So compression depth is based on chest size. Okay. So for all pediatric ages, at least 1/3 of the anterior posterior diameter of the chest should be the compression ratio. Okay. Okay. So absolute depth is used in adults, that is 5 to 6 centimeters. And always remember, rate is 100 to 120. Okay. And ratio single rescuer 30 is to 2, two rescuers 15 is to 2. I hope that is clear. Okay. Now, question number 26. Microbiology technician. Okay, so sterilization by a flaming loop. This method is called as incineration. Oh my God, I think this is a very easy set. Na? Okay, there is complete burning of the contaminants. So you have direct flame or the high temperature destruction. Okay, that's incineration. If it was thinalization, it is intermittent steaming. Okay, it is intermittent steaming. If it was filtration, it will remove the microbe, okay, by passing through a seal. And pasteurization is for mild heating. Okay. Now, question number 27. Okay. A very widely asked PYQ of a whip form. Okay. So there is a fleshy mass protruding from the anus. So that is a rectal prolapse. Okay. Rectal prolapse. Now, this is a classical barrel shaped egg with bipolar mucus plug. What else to think of? It is the trichurus, tricura. Okay, it causes rectal prolapse and dysentery. Okay, now ascariasis, the history would have been obstruction. Okay, and ankylostoma would have caused iron deficiency anemia. Enterobius would have given a history of perianal itching. Okay, now question number 28. So needle stick injury and you give a post exposure vaccine. It is hepatitis B. Okay. Question number 29. Now they are asking there is a Zika exposure. When should you attempt consumption? Okay. So couple traveling to an area with Zika virus infection, both are asymptomatic. They're asking when is it safe to conceive after return? Okay. Always remember that Zika can persist longer in semen than in blood. Okay. So always remember, okay, for men, you wait at least 3 months, and for women, you at least wait for 2 months. Okay. So for couples, always go with the longer time. That is the male factor. So wait at least 3 months till the last exposure. Okay. Now, question number 30. Okay. This is also a PYQ. So what does it say? COVID-19 public health advisory. What is the non-evidence based strategy? Okay, it is mass prophylactic administration of ivermectin. Okay, there is no strong evidence for preventing infection or reducing transmission. Whereas universal vaccination, mask use, hand hygiene all have strong evidence. Okay, next question. Another drug which was used was the remdesivir. Okay, then many COVID cocktails and all were there. So now there is a patient with a chronic cough, cavitatory lesion, and low ADA. Okay, okay. So there is cough, weight loss, low grade fever. Okay, and ADA level is very low. So it is actually a non-TB cause. Okay, but the symptoms very much looks like TB. Okay, And there is no history of any asthma or any central bronchitis or any sinusitis. So if it was sinusitis was there, then it would have been a diffuse panbronchiolitis, and there would have been diffuse nodules. ABPA history of asthma would have been present. It's not PTB because ADA is low, so it is an atypical mycobacterial infection. Okay. Question number 32. So there is a hydrated cyst. They are asking for the best management. Best management hydrated cyst is puncture, aspiration, injection, re-aspiration. Okay. And albendazole. Okay. Open surgery is always reserved for ruptured cyst, large complicated cyst, or multiple daughter cyst. Okay. Albendazole alone works for small cysts. Okay. So here you have a 7 centimeter lesion. So that needs to be aspirated. Okay. Less than 5 centimeter, you can go for albendazole alone. Now, question number 33, again conceptual. So they are asking TTP is a okay. So A and B are right, and that is the correct explanation. So in TTP, there is reduced Adam TS13, which will lead to increased ultra large von Willebrand factor, leading to platelet aggregation, microvascular thrombosis, hemolytic anemia plus thrombocytopenia plus organ damage. Okay, so both are right and both are the correct explanation. Now, what is the PENDAD? PENDAD is thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms, renal dysfunction, and fever. This is the classical PENDAD. Okay, this is the classical PENDAD. Okay, now question number 34. What does it say? You have a histology finding of BPH. Okay, benign prostatic hyperplasia. Okay, there is a glandular and stromal hyperplasia. Okay, so there are English gland with fibromuscular stroma. So it is a post BPH. If it is adenocarcinoma, you would have seen small crowded glands and all. Okay, acute bacterial prostatitis, you would have seen many neutrophils, and SGPIN, it would have been atypical epithelial cells. Okay, now question number 35. So they are again pheochromocytoma. What is the most likely metabolic effect? Okay, so there will be excess catecholamines leading to increased glycogenolysis, increased gluconeogenesis, decreased insulin secretion as well as increased lipolysis, leading to hyperglycemia. Okay. Okay. It is not lipogenesis, it is lipolysis. Okay. It leads to increased basal metabolic rate. Okay. Now, question number 36. Child with oral ulcers on palms and soles. So it is most likely to be HFMD. And HFMD is caused by Coxsackie A virus. Okay. A16, A6, they are the most likely culprits. Okay. Adenovirus causes pharyngitis, conjunctivitis, urethritis, diarrhea, and all. Rota causes diarrhea. Hepatitis B would have been a chronic liver disease, not a rash like illness and all like this. Okay, now question number 37. They are asking which is the incorrect statement of lacosamide. So, mechanism of action of lacosamide is actually enhances slow inactivation of voltage gated, enhances slow inactivation of voltage gated sodium channels. Okay, and stabilizes the hyperexcitable neuronal membranes. Okay, okay. Whereas phenytoin, carbamazepine, all will have fast inactivation. Okay, okay. Now, question number 38. Okay, now they are telling there is a refractive change due to a corneal lesion. Okay, so any corneal lesion, what is this corneal lesion? It is actually a pterygium. It is a wing-shaped flap of conjunctiva. So any corneal lesion that distorts the curvature will cause astigmatism. So here there is irregular corneal surface. So it will be a irregular astigmatism. Okay. Against the rule will be a regular astigmatism. It will be a regular astigmatism. That is horizontal more than vertical curvature change. Whereas this should be a with the rule or an irregular astigmatism. No, no, with the rule is also regular. With the rule is also regular. So it is an irregular astigmatism, not with the rule. Okay, because corneal lesion, scar, keratoconus, anything, it will cause irregular astigmatism. Okay. Now, question number 39. Now they are asking the CA column. Okay. So FAP is caused by APC. Yeah, that is true. Huge is by STK11. Yes. Juvenile polyposis by SMAD4. Yes. Tuberous sclerosis TSC1 or 2. Yeah, all are correct. Okay. Now, question number 40. What does it say? Menopause diagnosis. What is the lab marker? So, in menopause, ovarian function decreases, estrogen decreases, and hence the negative feedback is removed. So what happens when the negative feedback is removed? The FSH will rise sharply. Okay. So it will be FSH more than 40 MIU per ml. Okay. LH also rises, but it is less reliable than FSH. Now, 41. Okay. When do you say IHC is equivocal? So IHC is equivocal when it is 2 plus. Okay. If it is 0 or 1 plus, no, it is negative. No further testing is required. If it is 2 plus, it is equivocal and you should go for fish. If it is 3 plus, it is positive. Okay. No fish is needed. Okay. Now, 42. Okay. Okay. So we need the incorrect statement. Okay. DMD, yes, it is X-linked and it's a frame shift mutation in the DMD gene. LHON is a mitochondrial disease. Okay. Cystic fibrosis, most common is the delta F508. Okay. And Huntington, it is not a CTG. Hunter is in a cage. CAG. Okay. If it was myotonic dystrophy, it will be CTG. Can't tolerate grip. If it was fragile X, it will be congenital giant gonads. CGG. And if it was Friedreich's ataxia, it would have been GAA. Okay. Also in spinocerebellar ataxia, it is CH. Okay. Now question number 43. Okay. There is a okay role of thoracic epidural analgesia. Okay. What is the best reflecting role here? Okay. So in flail chest, there is where there is multiple fractures. Okay. There is pain which leads to hyperventilation, which leads to so there is pain leading to hyperventilation, leading to atelectasis, leading to pneumonia. Okay. So the goal of management should be to improve ventilation and reduce the need for mechanical ventilation. So what did you give? You give a thoracic epidural anesthesia, analgesia. First option is it is absolute contraindication. No, it actually improves respiration. Then they say relative contraindication. No. Okay. But actually, it is relatively contraindicated in hemodynamic unstable patients. But still, that is not the perfect answer here. Now, it is avoided due to dural puncture risk. No, 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 not a primary concern here. Dura and all where spinal anesthesia. Okay, that's it. Now, question number 44. So, this is a like what is the clinical step in metastasis? So, the key driver. So the key driver transcription factors are actually from the snail family, twist family, and the Z family. Okay, this is actually a new information for you. Okay, so see, snail family is a epithelial mesenchymal transition master regulator. Okay, P53 is a, but you can rule out and then decide. P53 is a tumor suppressor gene. RAS is a proliferation signaling gene, and HER2 is a growth factor receptor. Okay, so the answer is now 45. So HLA-B27 gene. So there is a classical angst patient. Okay, it establishes a definitive diagnosis. No, HLA-B27 is only an association marker. Like it is possible in almost 90% of cases only. Okay, screening for all inflammatory backbone. No, not a universal screening test. Okay, rules out other uveitis causes. No, HLA-B27 is positive in psoriatic arthritis, and IBD relative arthritis, and reactive arthritis. Okay, so appropriate clinical context. Okay, the criteria has HLA-B27. Now, 46, again, we discuss this question: internal rotation, extension, restitution, external rotation. Okay, now 47, for 12-year-old boy diagnosed with growth hormone. So, growth hormone binds to the growth hormone receptor. Okay, growth hormone receptor is a JAK2 cytoplasmic tyrosine kinase activator leading to STAT pathway signaling. Okay, JAK-STAT. Okay, so cytoplasmic tyrosine kinase activator JAK2. Okay, so growth hormone it is JAK-STAT or the cytokine receptors. Insulin it is the intrinsic tyrosine kinase, and the SHACTH has the GPCR, whereas steroids has the nuclear receptors. Now 48, prazosin produces balanced vasodilation via alpha protein. Yeah, true. Hydralazine relaxes arterial smooth muscles, decrease diastolic BP and reflex tachycardia. True. Clonidine reduces sympathetic outflow by acting on central alpha 2 receptors, decreases heart rate, systemic vascular resistance, also decreases BP. True. Propranolol lowers BP by reducing PVR. Nope. Yeah. Propranolol initially causes reduced cardiac output because it causes reduced heart rate and contractility, and then it causes reduced renin secretion leading to decreased SVR. Okay, so initial main effect is not the reduced PVR, it is the reduced cardiac output. Okay, now 49, patient presents with an injury to superior gluteal nerve. Okay, so again, Trendelenburg sign, it is due to gluteus medius and minimus. Okay, it is the failure of the gluteus medius minimus. We already discussed the question in the daily challenge. Okay, if superior gluteal nerve is injured, pelvis cannot be stabilized and contralateral pelvis drops. Okay, and there will be a waddling gait. Okay, last question of section 3. It is a 65-year-old patient. Now, what is the ophthalmic viscosurgical device key property? So, during phacoemulsification, it is used to maintain the AC stability, anterior chamber stability to protect the corneal endothelium and for a safe capsular access. That is why you ensure a OVD. Okay. So the best property required for continuous curvilinear capsularisis, the OVD would be high viscosity and good elastic or the cohesive properties. Okay. Yeah, that's it. Thank you. We'll see you on section 4. So let's start section D. So section D will go very fastly because like this goes in each section. The first page we have discussed quite in detail, like it has passed around 3 hours now. So we'll go in a very easy pace. Okay. So and very fast pace. Okay. So here now question number 1 in section 4 says splenectomy bleeding. So there is a surgery, it is an open splenectomy being conducted. And now there is a mobilizing superior column spleen scan in between the spleen and the fundus of stomach. Okay, greater cavity side. And what happens? There is suddenly burst of arterial bleeding and the vessel retraction with the pediment impact. Okay, now they are asking what is the most likely source of this. So the key structure here, key structure involved here is the gastrosplenic ligament. Gastrosplenic ligament. Okay. If the gastrosplenic ligament is actually being analyzed, and what happens then in very very short gaps. Okay, short gaps. These short gaps of arteries, they arise in the splenic artery. They arise from the splenic artery and supply the fundus system. They run between the stomach and the greater section of fundus. Okay. Okay. So when they are cut, they retract in the fat and it is like it's difficult to control. Okay. So the bleeding that is during the deviation of the gastrosplenic bleeding will be always the short gastric arteries. Okay. Why is it not clinically proper? Because you have already told the splenic artery after ligating the main splenic artery and being behind the surgeon proceeds to mobilize the superior portion of it. Okay. And what about left gastroepiploic artery? It runs along the greater curves. Okay, not near the fundus. Okay, and because the source of bleeding appears to retract into the perigastric tract near the fundus and not along the lower part, the greater curves. Okay, so fundus is at the superior pole. Okay. Now, what about axillary splenic artery? It's actually rare anatomy. Now, question number 2. So now they are telling there is a walking pneumonia. So walking pneumonia, we all know it is purpose. Okay. And micropneumonia, what are they asking? What is the correct finding? Okay. So the correct finding in micropneumonia will be IgM old abdominal types. IgM old abdominal types. IgM old abdominal. Why is it old abdominal? Because they cause the antibodies agglutinate the RBCs at lower temperature and simulates the IgM antibodies. Okay. So there is mild hemolytic anemia. Okay. Why do you get hyponatremia and delivery signs? You get Legion anemia. Why do you get red currant jelly sputum and bulging fissure sign? You get klebsiella anemia. Okay. It's also very severe, but not the walking anemia. Why do you get positive urine antigen test? It is really Legionella or Strep pneumonia. Okay. That's it. Now, question number 3. Question number 3 is a very high yield question. You can expect one for INCET, anti-TB drugs and the mechanism of action, especially the XDR-TB, the latest regime. That is the VPAL regime for XDR-TB. What is the VPAL regime? The VPAL regime for XDR-TB is Medaquilin, Ritomanib, and Limojol. Okay. What is the mechanism of action of bedaquiline? It is ATP synthase inhibition. What is the mechanism of linazole? It is 50S ribosomal again inhibition. And what there is another option given here. It's the inhibition of mycolic acid bioactive syndrome. And no, inhibition of DNA gyrase and topoisomerase drug. That is actually fluoroquinolone. Fluoroquinolone drug, they ask you in a pregnant female with a child developing cartilage cell. Okay. Mechanism of action. The terminal is inhibition of mycolic acid bioactive generation. React to right. Okay. Always remember bedaquiline is like battery. So ATP reduces. Retamine, small attack and cellular attack. And then the protein. Okay. So now question number 3 and question number 4. Okay. Okay. Now they are telling you there is a 28-year-old woman with recurrent DVT and APC resistance. So what is the next mutation? What is the next mutation that you expect? Okay. So you have a patient with recurrent DVT. APC. We've seen with normal acids, that is PT, APTT, and all are normal, and APC, activated protein C, is resistant. So this is a classical combination for what hyperparameter said. So it is a class B factor 5 data mutation or factor B data mutation. Okay. So what are the costs of hypercoagulability? It can be factor V data mutation or factor 5 data mutation, protein C deficiency, protein F deficiency, antithrombin deficiency. Okay, these are the well-defined causes of hypercoagulability. Okay. Now, prothrombin mutation, it will lead to elevated prothrombin. Protein C deficiency would impair anticoagulation. Okay, but there won't be any APC resistance. Antithrombin deficiency also is a different pathway. It affects the thrombin path inhibition. Okay, factor B or factor 5 mutation. Okay, CTAPDT is usually not. Now, question number 5. Question number 5 has been already discussed in the daily challenge. So you are telling the mechanism of action of some drug which is co-administered to reduce the transmission. So what is the key point that you need to remember? So you need to you need to kill the gametocytes on sexual forms. So the drug that kills sexual forms is actually prinophyll. What does prinophyll do? It is a gametocytocidal drug. Okay. It is given as a single dose of along with the ACT combination in falciparum malaria. Okay. So it prevents the spread. What does chloroquine do? It has the inhibition of the schizophrenia. It's a schizophrenia. Okay. And also has chloroquine also has a resistance to. What does metformin do? It is just a part of ACT and does not play any role in transmission form. What about doxycycline? It is also a prophylaxis or an antigen. Okay. Always be careful when you give Finally, be careful of these equipment. Okay. Next question. Question number 6. Similar question we had discussed in the previous DP, where you have a patient with acute gout and the patient has a background of CKD. Can you give NSAIDs? No. Why? Because there is CKD. Can you give high dose corticosteroid? No. It is a contraindication, actually contraindication for CKD patients. Can you give steroids? Yes. Okay. Yes, you can give. Does it have nephrotoxicity? Yes. Okay. What about allopurinol? Allopurinol is never given acute gout. So, in a case of acute gout, what are the primary treatments you have? NSAIDs, colchicine, and steroids. Okay, leukoparticles. NSAIDs, colchicine, leukoparticles. Then you have the treatment of chronic gout as the uric lowering agents, where you have uric acid, uricosuric drugs, right, which increases the uric acid levels in the urine, uric acid exposure in the urine, and peroxosatellite. So where there is sanguine oxidase in the urine. Okay. Okay. Now, question number 7. Okay, already. It is like what is oxygen conjugate? It's the shortest AP diameter of the inlet. It is the true conjugate. Then you have the DC, then you have the interspinal diameter, then you have the connective. Now, question number 8. What does question number 8 tell you? Question number 8 is an image-based test. Okay, this was my MBBS University short answer question. MIC or e-test. I think they asked the e-test, epsilon test. Okay. So, uh, there is a patient, ICU patient with pseudomonas aeruginosa, and the lab shows neuropilum susceptibility test. Okay. So, which parameters that directly tested? We have this MIC, minimum capability to concentration. Yes, sir. What is MIC? MIC is the lowest concentration of the bacteria, lowest concentration of the antibiotic. That indicates visible activity. So, MIC is the lowest concentration of the antibiotic that is in visible activity. Okay, it is a special. It is a microgram per time. Okay, next MIC. Okay, so what is NBC minimum macrocellular concentration? It actually requires a subculture. Where do you see a zone of inhibition? You see it in Kirby Boyer. Okay. You see Kirby Boyer is the diffusion. Okay, and there it is in diameters, not concentration. Serum bactericidal titer, no, it's a rare and specialized method. Okay, so this diffusion techniques and all, you get a zone diameter. Okay, zone diameter. That's a Kirby Boyer. Whereas in E-test or broth dilution test, you get the MIC. Moving on to question number 9. So what is question number 9? They are asking you what is the appropriate agent for RSI in a hemodynamically unstable patient or a shock patient. So you have a polytrauma patient with shock where BP is 50, heart rate is 130, hypoxia is there, SPP is 84, GCS is 8, and patient is sudden urgent intubation. Okay. So what will you give? You give ketamine, right? Ketamine because that's a symptom of myelin. Okay. Ketamine is a symptom of myelin. Okay. Hence, it increases the heart rate and the BPM. Also, it preserves the airway. Okay. So, ketamine is very useful in unstable patient. Yeah. Why rock? Rock because it is a rapid onset and it's good for RSI. Okay. It has a longer duration but a stable. Okay. That's it. Propofol recurrent propofol process. Hypotension. Etominate something. Etominate is hemodynamically stable. Okay. Remember, etominate is hemodynamically stable. So if they give an assumption to type and they say etominate is hemodynamically stable, don't think that it is wrong. No, it is right. But what does etominate cause? It causes continuous suppression. Okay. Because there is a sepsis bar critical illness, it can be a problem. Okay. And succinate means following causes hyperkalemia. Okay. Thiopentone ultrafilin, thiopentone causes cardiovascular depression. Okay. So shock plus RSI, drug of choice will be always given. Okay. Sorry, okay. Cardiac stable patients use propofol. And neuro, like ICP concerned patients use etomidate. Okay. Now, question number 10. 45-year-old male. Now they are asking me gold standard test for renal graft rejection. Okay, so there is a 3-month post patient with Malaysia loaded fever with a rising creatinine and nailed graft rejection. So this is problem with the graft rejection. So what is the degrees of possible changes?
can be golden indicator. Can you give immunosomes? So it can be some like tacrolimus, infection. Infection related to so it's the gold channel test for that, which is ultrasound can assist the blood flow and detect the obstruction. No rejection time. Tacrolimus levels, yeah. If tacrolimus is the cause for this rejection, you can handle it. Also, weaker virus, yeah, true. So less than 1 week, hyperactive. 1 week to 3 months or 12 weeks, active rejection. More than 12 weeks, well, always keep graph rejection in your mind. It's a very high risk. Okay. Question number 11. Okay. Hypertension pregnancy, you know, goal. So, 20-year-old Palmigravida, 10 weeks pregnancy, asymptomatic, first routine. Okay. So, what is the abnormality here? It is BP movement, BP of uncontrolled. So, BP more than or equal to 140 90 is the BP more than or equal to 140 is the so here the patient has 145 and 95. So definitely abnormal. If there is hypertension before 20 weeks. Okay. Because the system hypertension, the definition is at 20 weeks. Okay. So you need evaluation, monitoring, and possibility. Okay. Heart rate 95, mild increases there in normal pregnancies. So because of the increased cardiac output. HB 10.8, mild anemia is acceptable. Less than 11 is actually the top, but still hemodilution time. Okay. GFR 140 because pregnancy causes increase in GFR by about 50%. Okay. Yeah, now question number 12. Okay, question number 12 has been already discussed in the daily science. So this is the case of breast milk jaundice, right? Because it occurred after 1 week of life, it can persist for weeks and baby otherwise completely healthy. What if it's a 20-day-old baby, which is exclusively breastfed and baby is now active, feeding well, gaining weight, normal human foods with total delivery of protein and predominantly unconjugated. Like direct is 0.6. Okay. So it's actually just milk joints. Okay. In the milk joints, you continue taking injection. It was multiple doctors. Then the baby would have been sick. And it will be conjugated. And then child would have poor feeding. Okay, also the stool and diving fail. What are the red flag signs that you expect? Red flags are if you have same foods, if you have or if you have nothing in belly, always. Now, question number 13. Okay, what does question number 13 say? So, there is a history of um, genital ulcer, oral ulcer, and erythema nodule like lesion. That is tender nodule from the shin surface. Okay, and now they are telling there is positive ectopic. What is the positive ectopic? There is a skin prickness. So there is a positive ectopic. That's first two next person that skin prick. Okay, needle prick. So what is the classic? Classic diagnosis. It is bear shit. What do you see in bear shit? posterior uterus. Okay, posterior uterus. But it's another technical finding you can get information. You can you know. Where do you get starting off from the related to GPU? Where do you get Malabash? Talking of the weakness, volumes. That's number 14. Okay. Now they're asking you, what is the physiological function of the region indicated by the arrow? So they are actually asking for a photoreceptor anatomy. Photoreceptor has outer disc, the inner segment, and synaptic. Outer segment of the outer segment has the membrane discs. Okay. What does it do? It does water expansion. What does the inner segment do? There are no discs. And what does it do? It starts with mitochondria. So it is ATP. What does the synaptic terminal do? It releases the neuron. Neurotransmitter. So remember, photoreceptors have continuous adapter. Continuous adapter. Okay. So it requires high energy sodium potassium interface. Okay. And the segment forms the energy. Okay. That's it. Okay. Question number 15. What is the feature? Central Sterile Services Department. Okay. So, which is they are using sterilizing surgical instruments, linens, culture media to use a moisture plus pressure, which is the sterilization method that can be used is concrete. Okay. 121 degrees Celsius, 15 psi, 15 to 20 minutes. Kills the spores. That is the most important point. Is it not ETO? It is heat sensitive equipment. Okay, plastic and electronics are there. You can't use it. Gamma radiation, it is actually used for disposable syringes, catheters. Where do you use plasma sterilization? For the delicate machines. Okay, that's it. Okay. We have surgical instruments and all. Yeah. You can use ETO. Okay. Now, question number 16. What is the 45-year-old woman with a history of Crohn's disease? Now we are asking the best parental time for total dose injury. Okay, so what is the best parental time that you can give for PDA? Okay, there is a severe iron anemia with HB of 6.8 ml and oral irons not tolerated. Okay, so which one do you use? Iron, isomer. Why it's an isomer preferred? Because it can be given as a large dose, single input. Large single dose input. Large single dose. Also, it has low response. And it's a okay. And rapidly replenish the resources. So, I am isomers. Okay. What about FCN? There are carboxy maltose. It can also be given as a large dose, but it's not single. Single dose cannot be given. Multiple doses. Iron sucrose, multiple doses. Annually moderate cycle. Iron expand, single dose, but highly respond. Um, what? Anaphylaxis. Question number 70. Now, now they are asking ERA spot. Okay, that is enhanced recovery after surgery. Okay. Why do you have this? Which is to reduce the surgical stress, promote faster recovery, and to reduce surgical stress. That's faster recovery plus decrease the problem. That is why you will have the ERA protocol. So ERA's principle is actually continue, like ERA principle is for all these things. So I use what is the what is the deviation from the standard evidence components of the package? It's actually routine behavior in initiation beta blockers. Right? Why? Because beta blockers, like Nugent beta blockers and all just before the surgery can cause hypotension, bradycardia. Okay. Pre-operative oral carbohydrate loading, it reduces the insulin resistance and improves the recovery. TAP block is a multi-modal analysis. Early mobilization prevents DVT and epilepsy. So PRAS, what is the basic concept in PRAS? You do early PD plus early mobilization plus minimal fasting plus opioids there. It's actually a very big paragraph in Bailey. Okay. Because it has three PRAS techniques present, three months. Pre-op, intra, post-op techniques. Okay, now, person 18, 45-year-old female and super total diabetes for a large MNG. Now, they are telling there is a patient with two respiratory distress and biphasic spider with a high pitched and strained voice. So, it's actually bilateral arm systems. That's because it supplies all in this. Except try to pair. Okay. And what does happen? The water course cannot conduct. So they will do that. They will position. This conduction part is by the abductor is by the posterior temporal. Okay. Posterior by muscular parallel. Parallels. So adductors are partially conductors. So it is almost even. So you got the parallel. Okay. The cadaver point position is fully conducting position. Okay. Because when there is complete muscle paralysis, you get cadaver position. Okay. Unilateral versus bilateral. If it is unilateral, we have awesome. Here we want high pitched and straight. So by doing salting out, that is protein fractionation using ammonium sulfate. Okay. After the sulfification, supernatant this color. So they are asking which protein does not precipitate at 50% saturation. Okay. What is salting out? Proteins are precipitated. These in the size a large protein, it is less soluble. Okay. Okay. So Which one will remove the solution? Will be a small protein size like and it's the smallest part. But what about fibrinogen? This is a large protein. Alpha 1 antitrypsin refers to this earlier than us. Okay. So increasing solubility, what is the one order that we can derive? It is fibrinogen. 405. 405. Okay. Now, question number 20. Okay. So, you see a negative state. Okay. And what is it? Yeah. Yeah. Okay. Because can cause the mass like regions and pulmonary nodules or granulomas. Okay. The patient is actually having CD4 motor cellular pain. Because not HIV, please. Because not HIV. Okay. CD4 less than 100 is you, HIV related. Survivors, vegan problems. Yeah, it is true, but it is for yes. 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 Right. Because the first cafe is no common in completed. So, for less than 100, yes, no. Completed patient. And virus they say it is a positive occurrence because the reservoir is eukaryotes, not eukaryotes. Is that right? Now we want to question number 21. So 21 says there is a unit with delayed bleed. Okay. Where platelet is PP is normal. So there is bleeding despite normal vibrations. So what is it? That's really I factor because factor 13 actually factor 13 actually cross-links the fiber. Cross-links the fiber and stabilizes it. Cross-links the fiber and stabilizes it. Okay. So without it, clot initially forms. But clot combines. So we another incident will somebody tongue bleeding. Okay. That is also very important. And the patient has high risk for infection. Question number 22. 75-year-old male with elderly male back pain, elevated levels of pain, which can be the primary emergency. What does the spine X-ray say? Spine X-ray actually they told there is no sacral toxic is actually the pelvis extra. Okay. So you see what are these? You see metastasis. See, you see multiple metastasis. So what does this mean? That is a bone metastasis factor. Okay. Okay, so you get the osteoplastic So what is the process? Violet RCC, RCC process. Also, multiple myeloma has multiple lytic lesions where ALP is usually not. Okay, and RCC hypercalcemia. Okay, bronchial calcium also like okay. So prostate is blasted, whereas RCC CL are like question number 23. Okay, that's question number 5. We see there is a Machiari syndrome plus there is a hemolysis. Okay, so hepatic veins thrombosis plus always with anemia, elevated LDH, then reduced hemoglobin. Okay, so this is anemia, elevated LDH, reduced hemoglobin. So basically, reducing what was it? Intra, intravascular. What do you see here? Yes. Yes. Because there is a implementation in the figure become there is decay accelerating time. CD 55 innovation, CD 59. And the analysis become susceptible to complement mediated lysis. Okay. Why do the venous thrombosis? Because there is free hemoglobin which scavenges the nitrous oxide N1, and that's leading to platelet activation and endothelial dysfunction. Okay. So there are unusual bleeding at various sites like thrombosis at the hepatic veins, portal veins, the cerebral veins. Okay. Why is not factor B latent mutation? It is an inherited thrombophilia. We already discussed. Not only mutation, only thrombosis, no hemolysis. Protein C also only thrombosis. Okay. There is a morning hemoglobinuria plus Machiari condition about question number 24. Question number 24 is so they're asking for a athlete with the amenorrhea. What is the hormonal profile? So you have a long distance runner with a lower BMI. Yes, there is calorie restriction as well as intense exercise, and there is secondary amenorrhea for 7 months. So the time is functional hypotension. Functional hypothalamic anemia. What is the mechanism? Because of reduced energy deficiency, there will be hypothalamic suppression and leading to hypothalamic suppression is there, leading to reduced level of GLM. The hypothalamus and this reduced level of electricity and elements. Right? Reduced level of oh, okay. This is the final pattern of reduced elements. High emphasis, high inlets, low external. I will get this class information. That is high inlets, normal emphasis, normal external. You get to 6 years. When you normal emphasis, high prolactin. Gastro, okay. Question number 25. Okay. And then, 28-year-old woman, okay, with the infertility and has a normal one. Okay, because regular cycles are there, normal tubes are there, existing normal ovarian reserve because AMH is 2.5, normal semen analysis. Okay, it is actually unexplained fertility. And then infertility. And the next step will be ovarian stimulation with chemotherapy, right? Okay. Because it will increase the number of oocytes, increase the number of sites, it will improve the sperm delivery timing and enhances the chances of fertilization. Okay. Why not do IVF immediately? Because it's an invasive and expensive procedure. So you give it for, you reserve it for paid IVF. And then tubal block. It's a severe block. All this solution IVF. Diagnostic laparoscopy is stupid. No indicator. Endometriosis and all. Okay. Question number 26. What is question number 26? There is a 28-year-old again ascending weakness with autonomic instability. What is the best thing in the therapy? What's the idea? Ascending weakness, reflexia, diarrheal illnesses there, history is there, capital infection can be there, autonomic signs are there, and post-lytic capacity is similar. So first time we can be okay, IVH will neutralize the autoantibody. That's all. Okay, and it will also moderate the immunity. Okay, so this is good. Why do you prefer IVIG and versus laparoscopy? Why do you prefer IVIG? Because it's like easily available and safe. Laparoscopy we never mentioned. Okay, and it is not always superior to IVIG. So why do you give IVIG as soon as possible? Because there is an impact of fail. Okay, question number 27. 4-year-old interview. So, okay. So, there is a pediatric patient that spontaneous breathing with the breathing circuit where you have a nasal deep veins. Okay. So, what's the minimum FGF to prevent the rebreathing? 3 to 3 times the patients. Okay. So, in actually a rule for fundamental ventilation, it should be 2 to 3 times the minute ventilation. Why? Because it ensures expired carbon dioxide is flushed out and it prevents the rebreathing. Okay. So, spontaneous breathing from a person is 2 to 3 times the minute ventilation. When you give controlled ventilation, lower flows. Best for spontaneous breathing is mechanism of A. And because best for controlled ventilation is mechanism D. Okay. Question number 28. There is a deep transfer sample. Okay. Now they are using labor recept, second phase, plus 2 station. BTA is there. You need to do a rotational process delivery. You rotate to PTA. Okay. Which is the best process? Best in the experience process. Okay. Then markers can be used for transfer. Symptoms can be used for more than 10 to vertex delivery. Let me use 5%. 5% is given. Immediately increase. Never use for rotation of vertical. Okay, so heel and is used for rotation. Now, question number 29. This paper is fully filled with OB-GYN infection therapy. Okay, so that is a stable ectopic pregnancy. What is the best management? You give a single dose of intramuscular pregnancy. Okay, 6 weeks anemia, mild pain, hemodynamically stable patient. Minimal swapping for the previous shows that entry used small administered mass of 2.5. Okay, so mass is less than 3.5 to 4 centimeter, go for the okay. When you have a stable patient, no cardiac activity, beta HCG is relatively low. This is a classical unruptured, unruptured ectopic shrinking buffer. Okay. So laparoscopy is only when ruptured ectopic. Expected management only very low beta HCG level. Salpinch of strongly circular and not this first line. Okay. Question number 30. Okay. So that is an instance of the pain stools and conjugate joints. Okay. We discussed this previously. So conjugate hyperbilirubinemia, it can be mostly PhD. What is the treatment? Is as in the and when should we do it? We do it before 6 to 8 weeks. Because if there is a delay, there will be progress of fibrosis, cirrhosis, and liver. That's question number 21. There are see, it is the strongest HLA association in celiac disease. This HLA, okay. Also, you can eight. First, these molecules are eventually assembly. Each molecules assembly will have their label. Yes. Zs in HLA-D27 and for HLA-DR4, RA, HLA-D27, HLA-D4. Question number 32. Okay. Negate your role with test positive, fishy order, this is vascular, arterial, syrups. Possible, nothing but that. Yes. Okay. So, organism which replaces the normal lactobacillus. That's it. Trichomonas, there will be strawberry cell for feeding cell. Now, question number 43. So, again, anti-epileptic mechanism of action. Okay. So, there is an inhibition of GAPA transfer. One. Yeah, what about levetiracetam? It can be synaptic to pay complete. What about levetiracetam? Calcium channels. What is the original vacuum? irreversible inhibition of GABA. Yes. Yes. Targeted temperature management. Okay, so it is used when chromatostation rapidly recover spontaneous solution. What does it do? It reduces the cellular metabolism and it prevents the repercussion injury and also improves the immunity. Okay, so the core principle should be maintained for at least 24 hours, followed by slow rebounding. 1 to 5. Okay. So slow rebounding will increase the cerebral edema, electrical system, human edema. Okay. So in targeted temperature management, we do a controlled cooling plus 24-hour maintenance plus slow rebounding. Okay. Question number 35. So, accessories and types, environment. So, in severe hemolytic anemia, there will be indirect or unconjugated bilirubin predominance. Okay. And what is it? Liver cannot convert all heat to bilirubin in a conjugated form. So, unconjugated bilirubin is insoluble. Question number 36. What is it? So, that will then asking for a variety of predominant. Yes. Okay. And I love you. Predominant areas. Here from us with an architect. Okay. On sequential. The most, the best, or the best evidence is by meta-analysis. Question number 37. So there is a patient with CTPA showing normal large pulmonary embolism. So what is the um, primary? It is following this. It's the primary resulting feelings weak use relationship. So primary resulting changes that regulation, but not partition because of that what block or an environment. So that is the basic physiological difference. Regulation. Physiological difference. Okay. And when does intrapulmonary shunt occur? It occurs when perfusion is present and ventilation is present. What is it present? So air goes in, but home blood travels. That is that's it. Question number 48. What does it say? 24-year-old lady with a stepwise high-grade fever with a related granite site, rose spots, and salmonella type. So it is typhoid fever, which is pharmacologically unsuitable. What about septic? Septic is a oral septic it's effective in typhoid. Ciprofloxacin again it has good intracellular penetration as an answer. DNA gyrase. Azithromycin excellent intracellular accumulation and effective in persistent typhoid, which cannot be used with ampicillin. It is an aminoglycoside. Ampicillin is an aminoglycoside. What to say? So, it acts on 30 plus and requires oxygen pente. Whereas salmonella typhi is intra bacterial intracellular but aminoglycosides not penetrative. We can do that. I'm pressing for salmonella typhi. Now, question number 20 is so again on busy. So there is an inactive which is with endometrial changes. Endometrial biopsy shows glandular separation, stromal edema, just bilateral. What does they say? They say there is a secretory fluids. Endometrial fluids. When you have a secretory phase, there is conversion of proliferated endometrium to secretory endometrium with increased glandular secretion and stromal edema, and there is a potential for implantation. This what about chromatin citrate? It causes ovulation in action. That's an allergy disorder. Selective insulin receptor. Leuprolide is a DNR agonist. It suppresses the feeling of inflammation. So it's used for down regulation and not for secular problems. Ethanol estradiol is peaceful. Okay. It is used in proliferative state space and not only secretory transcription. Okay. Question number 40. Okay. Last question, 10. Okay. So 31 plus 6 weeks labor, cord collapse. Next management, cord collapse also we have discussed in the which one? Ladies and you kindly don't do it. So, five, because there is a bag of works presentation and all. Okay, this critical time you can practice acute fetal hypoxia consent. So maybe not the fetal case. 41. Now 41 says so we are giving accommodating services and then refractory hypotension. Okay. So what is the cause for this? So we have already discussed that is intermediate induced adrenal suppression. Okay, intermediate induced adrenal suppression. So there is blockade of level beta. Okay. So intermediate inhibits the adrenal enzyme 11 beta hydroxylase. Okay, that's it. And hence blocks the cortisol synthesis. Okay. Now, question number 42, fast pain. Okay. So fast pain is carried by myelinated fibers, by A delta fibers, whereas slow pain is by unmyelinated C fibers, which is the second pain. Okay, very good. Fast pain versus slow pain. Okay. Question number 43. What does it say? So classical ECG, they always give us info with the family history with ECG showing see V1, V2 changes. Okay. What is the hallmark changes? There is a COVID ST signal. V1 with the negative T wave and then 0 RB. Okay, that's due to its growth. What happens in Gurukula? There is a sodium channel. CN, sodium channel. Okay, leading to ventricular arrhythmias and it's called sudden cardiac. Okay, WPW, there will be short PN. ARVD, there will be epsilon units and RB values. Longevity would have heard prolonged. Okay, that's it. Question number 44. What does 44 say? 44 says there is 42, yeah, which is the laparoscopic entry instrument for using it. This is actually okay, for introducing carbon dioxide into the peritoneal cavity. Where do you use Hassan cannula? It is a open technique. Where do you use Silverman and all? Bone marrow biopsy. Where do you use two piece needle? Okay, two piece needles which use the epidural. Okay. Now there is a trocar. Okay, trocar and a vaccine. Okay. Now question number 45. When do you call? Okay. When do you use fish? So you use fish. It's also already discussed in the daily challenge. So when do you use fish? When you have a herpes with the equivocal receptor, that is IHS for 2+. Okay, 2+. Now 46. What is 46 say? 6-year-old boy with chronic hemolytic anemia with HBsP. Yes, HBsP. English HBF and English HBA2. What do you want? Yeah. Okay. If it was beta cell leukemia, HBA2 will be increased, BS will not HBS. If it was autoimmune hemolytic anemia, no HBLC pattern. If the family anemia chronic disease, okay, that's it. Also, you see, there's a child with so that legs inside sickle cell. Underground. Now, what about 47? You can see, what is the child with suspected foreign body aspiration? Next step is always viewer, X-ray, and then loss of we discussed that daily challenge. Okay, of May 5. So, question number 48. What is 48 say? Okay, now what is the okay antenatal corticosteroid regime? If you are using dexamethasone, D is a 4-letter word. So 4 doses of dexamethasone should be given. 6 mg, 12 hourly, 4 doses. If it is beta methasone, B is the second letter. 12 mg, okay, 12 mg dose, and 24 hours, 2 doses. Okay. That's it. Now, question number 49. 49 says, yeah, there is a Turk syndrome. What is the Turk syndrome? You have a infection plus bradycardia plus hypertension. Okay. What is irrigated? 1.5% glycine. Okay. So, what is the classification? Is a dilutional hyponatremia because a hypotonic irrigation fluid is like glycine. Yeah. Leading to reduced serum osmolality and cerebral edema. That's why you get all these symptoms. Okay. Why not ammonia toxicity? Because they are not an acute inflammation. High spinal block will cause hypotension and not hypertension. What about hyperglycemia? Neurological like the CV picture is not explained. Now, Last question, question number 15, and a very beautiful question from psychiatry, which can be a very common area. Now, the patient gives excessively detailed, irrelevant, okay, excessively detailed, irrelevant explanations, irrelevant information. Okay, and patient eventually returns to the original sound. Goal directed thoughts are directed thoughts are in that. This is an aspect of service. What about tangentiality? Never returns to the original content. Like it is like a tangent onto effect. Tangents never move. It goes on and on and on. Flight of ideas, it is a scene mania. But links are actually understandable. That's rapid shifting mind. I agree with this. Using association, that's schizo, illogical, disconnected. Okay. So I suppose all these questions have been detailedly discussed. Okay. So all the best. I suppose you will do the best for your INI-CET. Okay. Thank you for the cooperation. Kindly go through all the daily challenge questions because all the daily challenge questions has been curated exclusively for you from the previous year INI topics. And almost everything has been discussed in detail. Okay. Kindly go through. Thank you. Have a nice day. Bye.